A very good afternoon to everybody. It is indeed a pleasure to invite you all for this inaugural iIGF deficiency program, which is a unique program which we have developed basically, which incorporates each and every aspect of IGF deficiency. This is a condition which is really common in terms of pediatric endocrine practice. There are a lot of issues in terms of evaluation, in terms of assessment and management, and many of these problems are actually not really catered for in terms of appropriate finance. So what we have done is that over the next 2 hours or so, we'll focus about the various aspects of IGF deficiency, right starting from pathophysiology, which is in itself a complicated issue, to take over in terms of when to think of the conditions, which will be discussed by Dr. Neha. Then we'll take forward with regards to the evaluation, the etiology, going forward in terms of the role of IGF-1 and BP3, which Dr. Sajali will take over. Then we'll have the growth hormone stimulation and dynamic test. Dr. Riddhi will take over. Then subsequently, we'll talk about in terms of management, in terms of the conventional GH therapy, the long-acting GH therapy, which Dr. Chetan will be talking about. Subsequent to that, we'll talk about pubertal modulation, the role of GnRH analogs, and the role of aromatase inhibitors, Dr. Pratik, and finally IGF deficiency. So this is going to be overall a compact program of 2.5 hours in which we'll cover a lot of these things, starting from basic pathophysiology to the different aspects, covering different the whole aspects and gamut of this disorder. So before we start, we have got our panel which is there. So we'd like to welcome all of you. We have got Dr. Chetan Dave, who is working as a pediatric endocrinologist. He has been part of our team. Dr. Chetan, welcome. How are you?
Yeah, I'm fine.
So Dr. Chetan is currently working as a pediatric endocrinologist at Rajkot, his Center for Pediatric Endocrinology and Diabetes, and he has been part of our team. And you'll be focusing on what part, Dr. Chetan? Dr. Chetan
I will be focusing mainly today on long-acting growth hormone preparation.
Yeah. And then we have got Dr. Riddhi, who is in our department as a fellow for the last 2 years. So Dr. Riddhi, how are you?
Fine, sir. So I am talking about the IGF-1 therapy and the dynamic test, which is used for evaluation of growth hormone IGF-1 axis.
We have got Dr. Neha Agarwal, who is working in the Himalayan Institute of Medical Sciences in Dehradun, again part of our own alumni. So Dr. Neha.
Yeah, good afternoon, everyone. And I'll be speaking on the pointers and criteria that will help us identify the IGF deficiency patients.
We have got Dr. Sajali Mehta, who has just finished a fellowship in our institute and now working in Surya Hospital at Pune. So Dr. Sajali.
Good afternoon, everyone. Today I'll be discussing about growth hormone dependent peptides, IGF-1 and IGF-BP3 in details.
Yeah, and you've got Dr. Pratik Sen, who is going to talk about a lot about a very interesting topic of pubertal modulation. So Dr. Pratik. So Dr. Pratik will talk about GH and IGF modulation. We also got Dr. Sayan, who has just recently joined us as a fellow in pediatric endocrinology, and he is helping out in terms of the overall organization. So I think without wasting much time, what we will do is that we will directly go ahead in terms of the overall aspect of the program, and we will carry forward from that perspective. So as we've discussed, IGF-1 deficiency is one of the most common part of pediatric endocrinology, and this is one part which basically covers a lot of these issues in terms of clinical evaluation and the parameters which are relevant. So this is a very, very important aspect of pediatric endocrinology, one which is often missed and which causes a lot of confusion and problems in that regard. So what we'll do is that we will try to focus about different aspects of pediatric endocrinology and how IGF deficiency presents and manifests. So before that, we'll just give a brief overview with regards to what this whole program is and how this has really started off. So this is part of our MediClasses initiative, which has been working on for the last over around 10 to 12 years with regards to pediatric endocrine awareness. We started with workshops related to different aspects of pediatric endocrinology, moved forward to practical pediatric endocrine programs lasting for a full day, and we have had now around 11 programs. We then moved on to social media because we realized that it will be easier if we have all the material available on the website, making it much easier. And then we started our fellowship program. So I'm really happy that all of our students, starting from Chetan, Neha, Riddhi, Sajali, and Pratik and Saina, are now part of this program. So this is very good in that perspective and really satisfying. We started our online portal for medical education, which is MediClasses, focusing pediatric endocrinology as a key aspect. And then subsequently, we came up with our textbook, which is going to be updated now with an advanced version pretty soon, as well as the mobile application in that regards. So as discussed, we have organized a number of learning initiatives across the country. We have developed 6 core modules, which have been implemented across the country by over 100 workshops, over 10 programs, the PPECs, and a lot of these advanced courses have also been done. A lot of these information is now available on the YouTube. So there are over 120 videos available covering each and every aspect of pediatric endocrinology. And it has been seen by over 3.4 lakh people with a huge watch time. So this is the area where all the resources are available. But when we realize that we need to have a structured learning, because just having a view at a video at a time will give you information for that particular topic. But for a structured program, we really started a couple of years ago with MediClasses, which is basically a pediatric endocrine learning portal using validated tools and practical assessment to impart knowledge about different aspects of pediatric endocrinology. And we now have a very rich master course in pediatric endocrinology, which really covers the entire spectrum of pediatric endocrinology, over 90 modules, and we aim to take it to 100, covering a lot of videos, information. It's around 500 hours of video, at least a huge amount of text. We are going to come up very soon with 2 more advanced pediatric endocrine books. So this is going to be a lot of information up there and illustrative cases. We already have the basic pediatric endocrinology, and we are going to come up very soon, as discussed in the next 6 months. We should have 2 more books coming up on this regard. So we are also very happy to launch the MediClasses app, which really takes forward the knowledge gained from different aspects to a practical tool. So it uses algorithmic guidelines which have been developed, which help in terms of approach all the entirety of pediatric endocrinology, management of pediatric endocrinology, providing specific care. And we have now done a lot of validation in terms of DKA, growth application, our pubertal application, and a number of other perspectives which have shown to be quite effective in this regard. So it's basically a very easy something which you can just use and just answer your slow question. You get a precise answer in terms of the entirety of pediatric endocrinology. You put specific data with regards to a clinical condition, and you get management outputs out of it, and as well as validated analytics with regards to the bone age assessment, which is in fact a very powerful tool which has been found to be quite effective, as effective, or in fact maybe better than many of those methods like Bone Expert. So this is something which is available both on iOS and Android store, which you can access, and is going to be helpful on that. We plan to put up the video recording of this presentation on our website, the free section, from which you can access that. This has all been made possible by the entire team, which is led by Dr. Yutika. Then we have Pratik, Riddhi, Sajali, Chetan, Neha, Hemang has been an integral part of it. Dr. Mittal, Prabhatji and Sharabji have an integral part, and now Sayan has also joined. So this is like a whole teamwork which has really gone forward in this regard. So without digressing any further, I'll be focusing now about the current agenda, and what we're going to do is that we'll talk initially about the fundamentals which are most important in terms of the physiology, followed by pointers and criteria by Neha, and we'll then touch back to etiology, and then we'll move forward to the diagnostic section. So I think we'll start off directly with pathophysiology, and all we know is that the growth hormone releasing hormone is the key regulator of growth hormone secretion. It acts on the pituitary on its receptor to cause production of growth hormone, which is then taken off by the growth hormone binding protein. Now, this growth hormone binding protein is the extracellular domain of the growth hormone receptor, and the levels of growth hormone binding protein therefore provide us information about the growth hormone receptor defects, particularly the classical defect in the form of Laron syndrome. So if the GHBP levels are low, there is an extracellular domain defect. Now, this is very interesting because hardly any peptide hormones have a binding protein. So what does this GHBP do? This GHBP is basically avoiding the binding of growth hormone to the circulating receptors. So in a way, it is allowing greater amount of growth hormone to be used, and it is directing this growth hormone to its target site of action. So it's very, very important from that clinical perspective. Now, this growth hormone that acts on the growth hormone receptor, there are multiple places where it acts, but the most important site of action is the liver, where it acts to produce 3 growth hormone dependent peptides, and these are the 3 which Sajali will talk about when we talk about evaluation. The most important, of course, is the IGF-1, followed by IGF-BP and acid labile suspect. Now, all 3 of them form a ternary complex, and from there, they will basically move and be taken towards the target site of action, which is basically at the level of the chondrocyte, where the IGF-1 acts on the IGF receptor. So this is the conventional way of the GH-RH-GH-IGF system. A growth hormone is a complex hormone, a large hormone, a single peptide chain with some disulfide bonds which are there. This is basically a non-glycosylated protein with disulfide bonds. The reason we are focusing on this structure is that if you have to create growth hormone, it is not a simple biological process. It's not a simple biochemical process. It's actually a biological process. So process itself becomes important, and therefore, if you have a biosimilar compound which is produced similar to growth hormone, it has to go through the entire evaluation with regards to the overall aspects, with regards to the overall development in terms of the validation of that biosimilar, in terms of its biological activity and safety in that regards. Now, there are other homologs of growth hormone which are there in terms of prolactin, human chorionic somatotropin, and the human growth hormone from the placenta. Now, this growth hormone is produced from the chromosome 17, the gene which is there, the GH1 gene, which is a major regulator of growth hormone production. It is produced as a pre-growth hormone, which is then split into a signal peptide and a growth hormone molecule. Now, this growth hormone molecule then is basically there for release. Now, many of these large molecules, when we talk about growth hormone, we talk about insulin, we talk about AVP and PTH, they are all big molecules. They take time to synthesize. So they are actually stored in the vesicles. So growth hormone is stored in the somatotrophs, and from there, it is released under specific findings, and zinc plays an important role in that regards. Now, the overall process of development of somatotrophs is regulated by a number of genes, and this we know is a complicated pathway, but one which we need to really understand importantly. So we've got 3 basic group of genes which regulate the early embryogenesis in the form of the genes which involve the craniofacial development, like HESX1, SOX3, LHX3, and PITX2. These are the ones which are basically involved in early development of the pituitary. Abnormality of these genes will result in a clinical picture which will basically have a combined hypothalamic pituitary defect, visual, ocular, teeth, and as well as a number of other manifestations. The spine defects will be there, and they will have a multiple pituitary hormone deficiency. The second group of genes, the most important of one, is PROP1, is the ones which basically start acting to suppress the proximal gene. So the onset of PROP1 basically means that the HESX1 goes off and the POW1 F1 starts to work, and their defects are basically restricted to the pituitary. They do not have an extra pituitary phenotype, and they're mainly present with hormone deficiency. So we have PROP1, which causes the growth hormone, the prolactin, the TSH, the ACTH, and the variable gonadotropin deficiency. You've got POW1 F1, which causes the growth hormone, prolactin, and TSH deficiency, which we'll talk about a bit more when we talk about genetics in that regard. The key regulator of growth hormone production are the growth hormone receptor releasing hormone, GHRH receptor, as well as the GH1 gene. Now, what's very important to understand is while we say that there is a GHRH, IGF-1 pathway, which is the major regulator of growth, what we need to really understand is that there are multiple independent effects of these molecules. So GHRH is not just working at the level of producing GH, it is also working in terms of many other effects which are there. Therefore, the manifestation of individuals who have a GHRH receptor mutation will be different from other individuals. So in particular, if you have a GHRH receptor deficiency, the manifestations will not cause micropenis, will not cause hypoglycemia. So absence of micropenis, absence of hypoglycemia, which are considered to be a classical feature of the GHD. If you have a very short child, think of a GHRH deficiency. Similarly, we'll talk about when you have a growth hormone resistance, there will be a higher likelihood of things like sparse hair, like frontal bossing, which are more characteristic of growth hormone insensitivity than growth hormone deficiency. So there are GHRH effects which are independent of GH. There are GH effects which are independent of IGF-1, and that's very important to understand from that perspective. Now, this growth hormone secretion, as we discussed it, their major regulations at the level of secretion. Now, this is regulated by two antagonistic hormones. So we've got the growth hormone releasing hormone, which potentiates the growth hormone releasing hormone receptor, which is basically a G protein coupled receptor. It basically increases growth hormone production as well as secretion. Now we've got somatostatin, which inhibits this growth hormone release. So while GHRH is a continuously active hormone, somatostatin is one which is there in between. So what it is doing is that it is really allowing the pulses to form, and that is the important role. And if you have got high somatostatin, the growth hormone secretion decreases. Once they go low, it again increases. So this pulsatile secretion is related to somatostatin to a certain extent. A very potent growth hormone stimulator is the ghrelin, which is basically secreted by the stomach. When your stomach is empty, you are hungry, it produces ghrelin, which acts by the secretagogue receptor to cause stimulation of growth hormone. This has got two implications. Recently, there are compounds which have been developed, which are basically the secretagogues, which cause increased growth hormone secretion, and they are being used at least for diagnostics of GHD. And they will talk about one molecule which has already been approved in the adults at the moment. There are studies in children which are going on. Secondly, malnutrition will cause greater ghrelin secretion, and this will cause increased growth hormone. So malnutrition causes increased growth hormone, but body does not have enough energy to grow. So what does it do? So it basically does is that this growth hormone is high, but there is a resistance at the level of liver. So malnutrition is a classic growth hormone resistant state in which the growth hormone levels are high, but the growth hormone effect is less. And this is opposite to obesity, which we'll talk a bit later. Now, this growth hormone release is also influenced by a number of compounds like thyroxine, which is central for growth. It basically controls that. Then we have got the estrogen, which is a major stimulus of secretion of growth hormone. What it means is that in prepubertal individuals, both boys and girls, and as Pratik will talk about, that local aromatase production plays a very, very important role in boys. The growth hormone secretion will be low, and if we do not have a proper pubertal development or a priming, you will find that there will be decreased growth hormone levels, giving a false positive diagnosis of growth hormone deficiency. And this really highlights the importance of doing a sex hormone priming in this setting. Now, this growth hormone is inhibited by cortisol, which is an important mechanism by which it causes a decrease in that. So therefore, we need to ensure that the cortisol levels are normal and thyroxine levels are normal before we really go ahead with the growth hormone stimulation test. Otherwise, hypothyroidism will cause a false positive diagnosis of GHD. Hypocortisolism may actually have a false negative diagnosis of GHD. And in fact, certain situations like familial glucocorticoid deficiency type 1, which is because of the MC2 receptor defect, there is decreased cortisol effect causing increased growth. So cortisol deficiency, we always think about Cushing's causing decreased growth. Cortisol deficiency can also cause increased growth in certain situations. Now, of course, we have got the IGF-1, which will suppress the growth hormone production by its own feedback mechanism in that perspective. Now, as discussed, because of this combination of GHRH and somatostatin, we have these pulsatile growth hormone secretion. Maximum pulses happen around stage 2 to 3 of the sleep. And this is when we need to be really cautious in terms of having sleep disorders affecting growth. And this becomes important from a clinical perspective in that regards. Now, fasting is also important. If you're fasting, your growth hormone will grow. If you're not fasting, your growth hormone levels may be variable because of the ghrelin effect. So therefore, if you want to diagnose somebody's growth hormone deficiency, the ideal time to do a growth hormone stimulation test is in the morning in a fasting state in that situation. And very importantly, it may be affected by a number of other factors. So this understanding of the single slide really gives you a lot of information about pathophysiology of this entire growth hormone axis in that regard. Now, growth hormone basically acts to the type 1 cytokine receptor. It activates and binds to the extracellular domain, causing the approximation of these, resulting in an opening of the intracellular domain, wherein there is cross-linking, and this activates the JAK pathway, which stimulates STAT5. STAT5B is the major mediator of growth hormone effect. It basically goes to the nucleus, stimulates the STAT response elements, producing IGF-1, BP3, and ALS. So GH is ultimately causing the genomic effect, and that's why the effect is slow. There is a membrane effect, of course, but that's ultimately mediated by the STAT pathway. Defects in the extracellular domain, in the intracellular domain, in the JAK, in the STAT, in the SRE, in the IGF gene, or in the IGF-1 receptor will all result in what we can call, quote unquote, IGF deficiency or impaired IGF effect, for a very precise word in that regard. The growth hormone levels depend upon the stage of life. They are very low in the fetal period because the fetal growth is independent of GH. They suddenly rise after birth. That is basically because of lack of inhibitory compounds, and they then rise, and after that they trigger again in puberty. So the requirement of growth hormone will vary depending upon different ages. So physiological production will be around 25 micrograms per kg per day in childhood. It basically peaks around puberty to around 35 to 45. And this has resulted in certain recommendation that we should actually increase the secretion of growth hormone in that perspective, give the dose on the higher side, but that has not been proven to be effective in this situation. So we do not recommend a routine increase in the dose of growth hormone in this setting. As age grows, growth hormone's role on growth becomes less, but it is very important for around 25 years of age on bone, and that is why we talk about giving treatment for bone around 25 micrograms per kg per day, and then the effect is mainly at the level of adipocytes, which Neha will talk about, and this is mainly from adult perspective, and then finally we have a somatopause, after which the dose becomes less. Now the IGF-1 system is basically growth hormone dependent. Growth hormone acts on the growth hormone receptor to produce IGF-1 and IGF-BP3 and acyl-levine substrate. The IGF-1 acts on the type 1 IGF receptor. Now, this is the major mediator of growth. It causes cellular growth, prevention of apoptosis, and differentiation. So this basically causes increased growth. IGF-2 is also produced locally, but this is not growth hormone dependent. It has got minimal effect on the type 1 IGF receptor. We also have a similar compound. So insulin basically has got a homology to IGF-1, and insulin acts on the insulin receptor to cause growth as well as glycogenolysis, inhibition of ketogenesis, and anabolism. Now there is a structural similarity. So IGF-1 has got 5% effect on the insulin receptor, and therefore IGF-1 use will cause hypoglycemia. And this is something you have to be very careful about. And this we will talk about as to why we need to have a snack of carbohydrate before giving IGF-1 in that situation. Now, IGF-2 is mainly acting on the type 2 IGF receptor, wherein it causes growth inhibition. So this is a yin-yang phenomena. It increases at one side, decreases on the other. Other compounds like IGF-1 do not influence the type 2 receptor. Insulin, on the other hand, also acts on the type 1 IGF receptor, and therefore hyperinsulinism, because of whatever reason, in the form of potassium ATP defect, in the form of infant-to-diabetic mother, causes macrosomia. This insulin, of course, doesn't have an effect on the type 2 IGF receptor. So the effect of IGF-1, 2, and insulin depends upon how much they act on a particular type of receptor in that regard. Now, IGF-1 basically acts through the receptor which has got a alpha and beta chain, which is an inherent intrinsic tyrosine kinase receptor, stimulating the most important growth pathway, the MAP kinase and the PI3 kinase. Now, what we need to understand is that while growth hormone is predominantly acting through IGF-1, it also has got a IGF-1 independent effect. So IGF-1 will act on the IGF-1 receptor on the growth plate to cause increased growth. Growth hormone also have other IGF-1 independent effects. It has a direct effect on the lipids causing lipolysis, causing free fatty acid generation. It acts on the kidneys to cause phosphorus absorption. It acts on the bone to cause skeletal growth. It also has got a very important effect on the hepatic glucose metabolism to cause hyperglycemia. So growth hormone treatment will increase glucose, while IGF-1 will cause decreased glucose. This is a big dichotomy that we see in terms of therapy. Now, the other thing is that growth hormone also acts on the chondrocyte growth hormone receptor to increase IGF-1. So basically, it's not just the systemic IGF-1 produced by growth hormone, it's also the growth hormone which is being produced at the IGF-1 which is being produced at the level of the chondrocyte, which plays an important role in that regards, and that's pretty important from that perspective. So just to summarize from a very chondrocyte specific pathway, what we're looking at is that growth hormone is stimulating IGF-1 production in the liver, which is causing growth, but it is also causing multiple effects. So IGF-1 causes increased proliferation of the cells. It causes decreased apoptosis. So net thing is increased growth of the growth plate. Now this growth hormone also acts on growth hormone receptor in the bone to produce IGF-1, and which has a paracrine effect. So when you're giving growth hormone, you've got an endocrine effect as well, and you've got a paracrine effect as well. So this becomes very, very important in that treatment with growth hormone will be more effective as compared to treatment with IGF-1, because you've got both paracrine, endocrine, and a direct GH effect. The other major difference is that with growth hormone treatment, your IGF-1 will increase, but IGF-BP will also increase. So the amount of free IGF-1 which is being produced will be less, and free IGF-1 is a risk factor for malignancy. So growth hormone therapy has a lower risk theoretically of malignancy as compared to IGF-1, and this is a very important aspect when you want to compare in terms of IGF-1 therapy, and this is what we will talk about in that regard. Now, growth hormone also has a direct effect on the bone morphogenic protein, causing an effect in terms of the resting chondrocytes as well. So in a way, there are four parts of growth hormone effects, I would say. Production of IGF-1, which is systemic, local IGF-1 production, direct effect on the growth hormone receptor, and increasing IGF-BP. And that's why if you have a child in which growth hormone is also working and IGF-1 is also working, you don't have to think about anything, give growth hormone. In fact, the latest recommendations do say that even in IGF-1 deficiency, unless you have a genetically proven cause, you give growth hormone trial and there is no response, then you start worrying and thinking of IGF-1 in that regard. So this is very important. Just to summarize now the entire excess. So what we're looking at is that somatostatin and cortisol are inhibiting growth hormone secretion, causing decreased growth. Thyroxine is stimulating. And there is a direct link between the adipocyte and the growth hormone secretion. Ghrelin is basically increasing growth hormone, while in obesity, what is happening is that insulin is going to decrease IGF-BP, increasing free IGF-1. So basically, overnutrition, your growth hormone is low, but your IGF-1 is high. So this is a growth hormone sensitive state. And in adults, lower cutoffs have been recommended for obese individuals for GHD. This is not yet true for children, but this is an important to consider, that you may actually falsely label an obese child as GHD because of this insulin effect. Now, we also know that if you have undernutrition, as discussed, the GH is high, but growth hormone responsiveness is less. So undernutrition is a growth hormone resistant state in that regard. Very importantly, estrogen is also being produced, is an important regulator of growth hormone, and this is important from a priming perspective. Estrogen also has an effect on the hepatic growth hormone action. So if somebody is on an oral estrogen, you will have a suppression of IGF-1 production, and this will cause a lot of problems. So it is always preferable to use a transdermal estrogen, which really bypasses the liver. Otherwise, your IGF-1 level will go down. And estrogen also has an effect in terms of epiphyseal fusion, which is the final mediator in that regard. So oral estrogen decreases the IGF-1, while transdermal does not. And this is very important in that regard. And the role of estrogen is highlighted by this 13-year-old boy with growth failure. What we see is that this child was short, mid-parental height was normal, bone age was slightly delayed, he was prepubertal, and he was found to have low growth hormone and growth hormone stimulation test. Now, if you look at this chart, just memorize this: 99% of these individuals have constitutional delay of puberty and growth. Just below the growth chart, the bone age, which is the yellow dot, is within the normal range. So this you do not need to do a growth hormone stimulation test. If you do a primed test, and if he had given testosterone, his growth hormone response would have been normal in that situation. So this is a very important aspect to consider. So now we've already discussed a lot about pathophysiology. We will now move forward to more clinical parameters in terms of pointers and criteria. At this point, I'd like to also thank Pfizer India, who are our sponsors for this program, who have made this possible. And before we move forward, we will now like to invite Dr. Neha, who will talk about the pointers and criteria of IGF deficiency. And Dr. Neha has been our fellow in Regency CGER from 2017 to 19. And she is now basically coming in terms of, she's now talking, working as a senior resident at the Himalayan Institute of Medical Sciences, and she will talk about this very interesting topic in terms of IGF-1 deficiency pointers and criteria. Over to you, Neha.
Hello.
Yeah, Neha, start.
Yeah, thanks for the kind invitation, sir. So after a thorough discussion regarding the physiology and pathophysiology about the growth hormone IGF-1 axis, it would be pretty easier to understand the pointers and criteria of the associated conditions. So as we have already discussed that apart from the role of growth hormone and IGF-1 on the growth, it also has effect on multiple other organ systems. So starting from the physiology again, just to touch in a brief, secretion of growth hormone from the pituitary under the influence of growth hormone releasing hormone acts on the growth hormone receptor present on the liver, which causes the secretion of IGF-1. This IGF-1 causes an inhibitory effect on the production of growth hormone via two pathways. First is via the inhibition of somatotrophs directly, second is via the production of somatostatin, which in turn has a negative feedback on the pituitary somatotrophs. The IGF-1 produced circulates in the blood in two forms, namely the unbound form and the bound form. The bound form is mainly bound to IGF binding protein, among which IGF binding protein 3 constitutes the major form. Now, this IGF-1 plays a role in neural development. So the clinical implication of this effect is that newborns who are born with IGF-1 deficiency or resistant, these newborns, in addition to having short length at birth, also have neurodevelopmental delay, while newborns who would be born with growth hormone deficiency will be neurologically sound, since there would also be some growth hormone independent IGF production. Secondly, this IGF-1 plays a role in musculoskeletal development and growth, which accounts for the psychomotor delay seen in the patients of IGF-1 deficiency. Thirdly, this IGF-1 has a role in cardiovascular protection, and it also has a role in glomerular function of the nephrons. Together, these both hormones contribute to the maintenance of blood pressure, and deficiency in IGF-1 is important in production of metabolic syndrome, of which hypertension is one of the components. The most important role of IGF-1 is in the intrauterine growth of the fetus. Since we have read in the previous discussion that intrauterine growth is independent of growth hormone and is completely regulated by IGF production. So any deficiency or resistance in IGF action will lead to intrauterine growth restriction. So IGF-1, not only in the intrauterine period, but throughout life, has important physiological roles. As it can be seen from the graph, that circulating IGF-1 levels are maximum during the childhood and the pubertal period, and they gradually decline as the humans age. And this decline in IGF-1 contributes to many of the morbidities which are associated with aging. So during the early infancy period, this IGF plays a role in providing genetic stability by contributing to growth in neurogenesis, synaptogenesis in the central nervous system, and in the genitalia development. So as sir already highlighted, that presence of micropenis or undescended testis should alert one towards this IGF-1 deficiency or resistance. During the young period or the peripubertal period, this IGF plays a role in enhancing the bone accrual, in anabolizing effects, and in various proliferative mechanisms. While during the middle age period, it helps in the metabolic control by controlling the lipid and glucose metabolism, and it also aids in hepatic and cardioprotection. While during the elderly life, it plays a role in telomere shortening and contributes to the various comorbidity that are found during the aging process. So after going through the physiology and the role of IGF-1 at different stage of life, we now move on to the conditions which are associated with IGF-1 deficiency. So IGF-1 deficiency during the intrauterine period will lead to intrauterine growth retardation or restriction. It may present with Laron syndrome, and later these children or these humans are at risk of developing metabolic syndrome. The 5 major components of metabolic syndrome being insulin resistance, abdominal adiposity or visceral obesity, hypertension, dyslipidemia in the form of high triglycerides, and low HDL cholesterol. Because of the role in liver, heart, and kidney, this IGF-1 deficiency has been found to play a role in chronic liver disease, in cardiovascular diseases such as ischemic heart stroke, and also in other comorbidities. So since we are talking about growth in this talk, we focus on intrauterine growth restriction, Laron syndrome, and metabolic syndrome. So coming on to intrauterine growth, which is regulated by 3 important parameters, which are the maternal factors, placental factors, and the fetal factors. During the early weeks of gestation, when fetal growth hormone production is not present, placental growth hormone comes into picture, and which causes an increase in the circulating maternal serum IGF-1 level. These IGF-1 plays an important role in the development and growth of placenta. Any inhibition in the formation action of IGF-1 will lead to placental dysfunction, which will inhibit the movement of nutrients from the mother to the fetus, leading to intrauterine growth restriction. As already said, these newborns would be neurologically impaired because IGF-1 plays a role in the neuronal development as well. And also there would be a risk of metabolic syndrome in these children later in life. Metabolic syndrome, apart from the 5 main components described earlier, are also associated with PCOS, non-alcoholic steatohepatitis, and risk of stroke and cardiovascular disease in later life, and thus early identification and prevention of metabolic syndromes becomes important. This arises due to compensatory hyperinsulinism secondary to low IGF-1 level in the body, and replacement of recombinant human IGF-1 has been shown to enhance insulin sensitivity and reverse the components of metabolic syndrome. Third, IGF deficiency has also been shown to play a role in the pathophysiology of Laron syndrome. So talking about normal physiology, the production of growth hormone from pituitary gland acts on the growth hormone receptors on liver to produce IGF-1, and this IGF-1, by acting on IGF-1 receptor, plays a role in the growth, proliferation of cell, and inhibition of apoptosis. It also gives a negative feedback inhibition to the pituitary to stop the production of growth hormone. While in the pathology of Laron syndrome, there is the production of growth hormone from pituitary, but either due to a mutation in the growth hormone receptor or defective IGF-1 gene, there is decreased production of IGF-1, which causes a decreased feedback mechanism, and more of growth hormone is produced. So Laron syndrome is characterized by high growth hormone level with low IGF-1 and low IGF-BP3. Studies have shown that patients or newborns born with this condition have slightly short birth length, but birth weight is shown to be within normal limits, while those with growth hormone deficiency have an unaffected birth length since intrauterine growth is independent of growth hormone action. Because of overlapping features of Laron syndrome and those of growth hormone deficiency, it is important to identify and differentiate these patients from growth hormone deficiency because of the expense involved in the diagnosis and management of these patients. So apart from severe short stature, Laron syndrome is characterized by a typical facies, as sir already highlighted in the previous presentation, which is characterized by frontal bossing, sparsity of hair, glue sclera, saddle-shaped nose or hypoplastic nasal bridge, and maxillary hypoplasia. We also find crowding of teeth because of mandibular hypoplasia in these patients. The bone age or the skeletal maturation is delayed, and because of the importance of IGF-1 in musculoskeletal development, these children often have psychomotor delay. Summarizing the differences between growth hormone deficiency and growth hormone insufficiency, at birth, those with growth hormone deficiency usually have unaffected birth length, but those with growth hormone insufficiency are born with restricted growth. Facies of growth hormone deficient patients is more like a doll-like chubby facies, cherubic facies, while those with growth hormone insufficiency have a coarse facies in the form of frontal bossing and mid-face hypoplasia. Basal growth hormone, although is not recommended nowadays, but in growth hormone deficiency, if somebody is still doing, it has no role. While in growth hormone insufficiency, one may find growth hormone levels, basal growth hormone levels, well above the normal range. IGF-1 generation test, which will be discussed in subsequent presentation, is measurement of basal IGF-1 level and 5 days after giving daily growth hormone at 25 mics per kg per day. If there is a rise by more than 15, it goes in favor of growth hormone deficiency, while if the patient fails to produce a rise of more than 15, it goes more in favor of growth hormone insufficiency. So just to summarize, it is very important to differentiate patients from growth hormone deficiency since it plays a role in management, and these patients of IGF-1 deficiency are characterized by severe short stature with normal screening investigations and normal growth hormone levels. Presence of micropenis, undescended testis, cholestasis should alert the treating physician. And since IGF-1 has a role in neurodevelopment, presence of psychomotor delay should alert the treating physician towards the possibility of IGF-1 deficiency. Apart from the clinical pointers, there is an important role of doing IGF-1 assays and growth hormone, which will be discussed in subsequent class because there is quite a lot of confusion regarding the standards available for the current Indian population. Thank you.
Thanks a lot, Neha. So there are a couple of quick questions which are there. Dr. Naresh is asking regarding can IGF deficiency occur in adulthood? Neha?
Yes, sir.
Can IGF deficiency occur in adulthood? Dr. Naresh is asking the question.
IGF-1, since it is produced by liver, so if there is an IGF-1 deficiency, secondary conditions that, such as liver diseases should always be ruled out. And it can very well occur during adulthood period if the patient has acquired some liver-related disorder. So genetic causes of IGF deficiency are more likely to occur in the early childhood period, while acquired IGF deficiency can still happen at any age group.
Yeah, and I think what we are trying to say is that IGF-1 deficiency is actually also part of GHD. So all growth hormone deficiency are also IGF deficiency because ultimately they have a reduced IGF-1. So they can occur any time of their life. Dr. Naresh is also asking since what minimum age should we suspect GH deficiency in terms of slow growth velocity and short stature?
So growth hormone has minimal role to play in the intrauterine period. So these are usually born with a normal average birth length. And during the first 2 years of life, nutrition plays a much more important role as compared to hormones. And those with growth hormone deficiency, we can see faltering in growth starting by around 2 years of age. So if we are plotting longitudinally the growth of a child from birth, we may see that the child is faltering by around 2 years of age, which should alert the possibility of growth hormone. But before jumping onto growth hormone deficiency, other common conditions should always be ruled out, such as protein energy malnutrition, because IGF-1 will anyways be low in malnutrition as well.
Yeah, I think that's a very, very important point that usually 2 years will be the time when they'll start coming to us with growth failure. And often the diagnosis and treatment starts around 3 to 4 years. So it is critical from that perspective. So I think we'll thanks a lot, Neha, for a very nice discussion about pointers. And we'll move forward. We are also like to thank our sponsors, Pfizer, the makers of Genotrophin, who have made this program successful. We'll move forward now to the etiology of IGF-1, which is extremely important to understand because this is a wide spectrum in that perspective. So if we look into our entire physiology, which we discussed, starting from GHRH to GH to GH action, IGF-1 deficiency can represent either growth hormone deficiency or growth hormone insensitivity. Now, growth hormone deficiency can happen as part of a multiple pituitary hormone deficiency, and it's very important to identify that because there is a huge issue with regards to the overall overlap of the effect of growth hormone on thyroxine and cortisol, and vice versa. That becomes important, and this could be a tumor, insult, or a genetic cause, or an isolated deficiency which can be genetic and idiopathic. Remember, isolated idiopathic growth hormone deficiency in our older child is a diagnosis of exclusion. And we have to be very, very careful because we may be missing an intracranial lesion. So my major concern in an acquired isolated GHD is first, whether it's really growth hormone deficiency or not. And secondly, whether there is an underlying tumor in that situation or not. We can also have a primary problem like a growth hormone receptor, IGF-1 gene or IGF-1 receptor. This is basically a problem in which it's similar to a primary hypothyroidism or a secondary hypothyroidism. So this is a primary IGF-1 deficiency. And secondary abnormalities will include malnutrition, liver disease, which you have to always exclude before you diagnose growth hormone resistance or insensitivity. Very importantly, severe GHD in the setting of a growth hormone deficiency type 1, which is a growth hormone 1 gene defect, will develop growth hormone antibodies with treatment, and this will result in a picture which is pretty similar to a growth hormone insensitivity in that regards. So IGF-1 deficiency could be because of growth hormone deficiency or insensitivity. Deficiency can be multiple pituitary hormone because of malformation, genetic or insult, or infiltration, isolated because of genetic, idiopathic causes, and finally we can have a defect in the growth hormone receptor, IGF-1 gene, IGF-1 receptor, or secondary causes in that regard. So malformations are particularly important, and we have to consider them with early onset growth hormone deficiency. Particularly, this includes holoprosencephaly, which is basically a very severe defect in the forebrain fusion. So you will have things like cyclopia, you will have a single central incisor, there could be a microcephaly, and these features will really pick up very early. Early onset multiple pituitary hormone deficiency will be characteristic. Pituitary stalk interruption syndrome, if you see this MRI picture, this is very, very classical. What you're seeing is that your posterior pituitary is lying up. That looks like an ectopic one. The anterior pituitary is small and down, so it's not being able to go up. So this is basically an embryonic defect. And because the anterior pituitary is not going up, your pituitary stalk is interrupted. So this is ectopic posterior pituitary, hypoplastic anterior pituitary, and there's the problem of stalk. And this is a classic manifestation of what we call pituitary stalk interruption syndrome. Very common as part of an environmental insult, as part of a fetal insult, or as part of genetic etiology. And we can also have septo-optic dysplasia, in which there's a problem of the absent septum pellucidum, optic nerve hypoplasia, and this is something which is important to consider in a differential of a multiple pituitary hormone deficiency, especially if there is blindness, if there is roving nystagmus. Think of a septo-optic dysplasia in that regard. Now we've discussed about the genetic causes. They can be the early onset SX1, SOX3, LHX3, PITX1, PITX2, which will cause multiple other abnormalities like eye, ear, forebrain, spine, as well as teeth. So if you have these abnormalities, we're talking about proximal defects. They account for around 5% of all causes of multiple pituitary hormone deficiency. Then we can have defects in PROP1, which is the most common cause of familial MPHD. It causes deficiency of growth hormone, prolactin, TSH, along with evolving effects on ACTH as well as gonadotrophins. POwer1 F1 presenting very early with hypothyroidism along with GH and prolactin defect, which is there. Then we can have a GHRH defect and a GH1 defect. So MPHD can be part of HESIX1, which causes optic nerve hypoplasia, SOX2-SOX3 causing hearing and eye defects, PITX1, PITX3 causing sensorineural hearing loss, LHF3 causing a spine problem, absent pituitary stalk in LHX4, and PROP1 may actually cause an enlarged pituitary temporarily, which will look like a pituitary mass, and we've got small pituitary in POW1F1. So if you have an extra pituitary manifestation, many of these proximal genes are involved. If you have specific pituitary morphology, we are dealing with PROP1 or POW1F1 in that situation. Isolated GHD can happen in the setting of a severe defect in GH1 gene, which if you start treating will cause antibodies to form. GHD1B, which is a recessive form, a milder form. GHRH defect, which does not cause hypoglycemia and micropenis as we discussed, and it has got its own characteristic facial features. GHD2, which is variable, which progresses to multiple pituitary hormone deficiency, which may be sometimes reversible also in that perspective. And then we finally have an X-linked form. Now, these defects will present usually early with severe growth failure and will not have other interpituitary hormone deficiency, with the exception of GHD, in which we have a destruction of the other pituitary cells, GHD2, in which there is a splicing defect. So this accumulation of abnormal GH will destroy not only the somatotrophs, but the surrounding cells, causing evolving MPHD. Traumatic brain injury is an important cause of the effect. Now, what we need to remember is that growth hormone cells are on the periphery. So these cells are likely to be affected by not only the trauma, but also going to be affected in terms of vascular damage. So if there is a damage, this may evolve over time. There could be an acute abnormality in the form of HPA axis in DI, which improves over time. The most important chronic problem is growth hormone deficiency. So every child with a significant traumatic brain injury should have a growth hormone evaluation on follow-up. Very importantly, birth trauma, like a forceps delivery, like a breech delivery, can also cause a picture of growth hormone deficiency, and monitoring becomes important. Radiation damage is absolutely important to identify because this has got the maximum effect on the hypothalamus. So the GHRH axis goes first. With minor radiations about 12 where the growth hormone deficiency happens. So if you have got any hormone deficiency with radiation, GH will be the first one. So it has always be associated with that. There could be a precocious puberty beyond 18 days, and this precocious puberty may mask growth hormone deficiency because you do not have that decreased growth, because precocious puberty is pushing your growth. So this is the second condition in which the growth may be normal or in fact compromise with precocious puberty. The first one is of course hypothyroidism, which we have discussed. So low dose can cause early puberty. As the dose increases, we have the effect of the cortisol, we have the effect of the thyroid, and finally delayed puberty. So there is a whole spectrum in terms of radiation induction and the sensitivity. Growth hormone deficiency, very common. Everybody will have GHD in that perspective. Now, if we talk about the effect of cancer therapy on the growth hormone axis, radiation affects both hypothalamus as well as pituitary. We have got also effect of steroid, which is commonly used in terms of treatment of a number of conditions. There would also be the effect of cranial irradiation, which causes a spinal compression. So you may falsely overestimate growth deficits in a radiated individual, and if you give growth hormone, you will not get that much benefits, and you will have more disproportion. So generally, if somebody has received spinal irradiation, do not use growth hormone in that particular setting. Tyrosine kinase inhibitors are commonly being used in treatment of CML, and they actually inhibit the pathway of this IGF action. So this is something, a very complicated situation, will affect growth. This effect is more with younger individual, higher radiation dose and longer duration. Spinal growth, as I said, can be affected. And IGF-1 and GHRH are unreliable markers in this setting, because if you use the GHRH stimulation, because the GHRH deficiency is the main cause, you may have a falsely normal response in that setting. So assessment would be a growth hormone stimulation. Management is growth hormone after 1 year of correction. Infiltrative disorders like histiocytosis are very important between 2 to 5 years of age. So if there is a rash, seborrhea, particularly a polyuria, polydipsia, DI involvement, hepatosplenomegaly, think histiocytosis. Beyond 6 years, always think of a large lesion like craniopharyngioma. So if you have a lesion like this, which has got a solid and a cystic component, some calcification, pituitary rim, think of craniopharyngioma very importantly. And we can also have rat case cyst, which is a congenital malformation, which is basically an abnormality in the rat case pouch with the adenoidal epithelium in that setting. The growth hormone insensitivity can happen if there's a problem in the extracellular domain, in the intracellular domain, in the STAT pathway, in IGF-1 gene, and finally IGF receptor. So this is an entire spectrum which may be there, and the features are also different. So extracellular domain is what is conventionally known as Laron syndrome, is associated with severe growth failure with low growth hormone binding protein. Intracellular membrane has a postnatal growth failure with normal growth hormone binding protein. STAT5B defect will cause milder defect with immunodeficiency. ALS defects is very, very mild, so this is usually not being picked up. IGF-1 gene defect is something which is very important. So anything above the IGF-1 gene defect, the birth size will be normal, as Neha said. But if you have an IGF-1 gene defect, or if you have IGF receptor defect, they will be both prenatal as well as postnatal growth failure, and this will be extremely important to identify and manage in that perspective. So we have now discussed in terms of the etiology. We'll touch base upon assessment. The key questions to be answered are: is it IGF-1 deficiency? Is it growth hormone deficiency or growth hormone insensitivity? And finally, what is the cause? So to identify the IGF-1 deficiency, Neha very clearly said that we need to have a very strict oxological criteria before we go ahead with biochemical test. And this is our algorithm, which has been developed based upon our own patients. And what we have seen is that if the height is more than -2, nothing needs to be done unless they have a clinical pointed to disease. If it's between -2 to 3, you look for two things: corrected height SDS to exclude familial short stature, and a height standard deviation score for bone age, which corrects you for CDGP. If both of them are normal, you do some screening tests, which includes the whole battery: CBC, SGPT, creatinine, electrolytes, thyroid, and celiac disease. If it's normal, follow up. And if you do not grow or your height is less than -3 standard deviation, you look at your dysmorphism, disproportion, do a screening test. If they are all normal, do some nutritional workup like calprotectin, IgA, blood gas. And only after that, and only after the karyotype in a girl, should you do a growth hormone test. The reason for this is that these tests have a notorious both positive and negative predictive value. Somebody who is GHD may be missed, but somebody who is not GHD will also be picked up as GHD because there is a inherent errors in these assays. So it's very, very important to have your oxological criteria very clear. Your pre-test probability should be high before you do a growth hormone evaluation in that setting. Otherwise, it causes confusion in that regard. So in terms of evaluation of the GHRH, GH-IGF-1 axis, you can look at the growth hormone level, you can look at the IGF-1 level, you can look at the IGF-BP, or you give growth hormone and see how the IGF goes. So we'll now go into the various tests and how we can really evaluate. Now, this is an interesting case. 10-year-old girl, height is 120 centimeters, weight is 15 kgs. What we see is that she had mild anemia, TTD was negative, IGF-1 was low, and was referred as a IGF deficiency. Now, what we see here is that this girl is a classical nutritional cause of growth failure. And as Sajili will now discuss, is that we have to be careful in this setting in doing IGF-1 because IGF-1 is ultimately nutrition dependent, and this was falsely diagnosed as IGF deficiency. Now, we'll move forward to our evaluation part. Now, the next talk is from Dr. Sajili Mehta, who has just finished a fellowship at Regency CDDR and who is working as a pediatric endocrinologist at the Surya Hospital, Pune. And I invite Sajili to talk about the growth hormone dependent peptides. And Sajili, all over to you.
Thank you, sir.
Yeah, you can share the screen.
Yes, sir. Is it visible?
Yes, yeah.
Okay. So, good afternoon, everyone. I'm Dr. Sajili Mehta, and today I'll be discussing about growth hormone dependent peptides. So, the most important growth hormone dependent peptides, as discussed by Dr. Anurag sir as well as Dr. Neha, are IGF-1 and IGF-BP3. In addition to that, ALS also is an important growth hormone dependent peptide, but ALS does not have any biological function, and hence we will not be discussing about that in details. These two peptides combine to form a trinary complex, which then combines with ALS to form a ternary complex. IGF-1 exists most commonly in this form in the blood. These both peptides, as discussed previously, are produced by liver under the influence of growth hormone. So let's discuss them in big details. So insulin-like growth factors, there are two types, of which IGF-1 is growth hormone dependent. IGF-2 is not dependent on growth hormone. This IGF-1 is produced by the liver, and the production is different for different ages. In neonates, the production is very less, and it accounts to around 30 to 50% of the adult range. This IGF-1 production gradually increases as the age increases, and they reach the adult value at pubertal onset. And during puberty, the value of IGF-1 tends to shoot 2 to 3 times above the adult range, and this is affected by the sex steroids. And hence, while assessing the IGF-1 levels in pubertal children, one should correlate them better with the Tanner staging or the bone age rather than the age. So there are various factors that affect IGF-1 levels. One most important factor is the age, as we described previously, and also gender plays a role in IGF-1 levels. Males tend to have higher IGF-1 levels compared to females. The other factor is nutrition, which has been previously described, that nutrition tends to affect IGF-1 levels, and malnutrition is associated with low IGF-1 levels. The other factors are various systemic illnesses like liver disease. Since IGF is produced in liver diseases causes low IGF-1 levels. The other diseases like kidney disease, diabetes, severe trauma, or malignancy can also affect IGF-1 levels. The other thing is drugs. OC pills commonly affects IGF-1 levels and tend to cause lower IGF-1 levels. In addition to this, the hormones also play an important role on IGF-1 levels. Insulin, thyroid hormones, and steroids tend to increase IGF-1 levels. Similarly, sex steroids like androgen and estrogen in lower dose tend to increase IGF-1 levels, whereas estrogens in higher dose suppresses IGF-1 levels, which is also seen with OC pills. So going ahead with various assays and how to do IGF-1 as sampling. So IGF-1 is normally done on serum. Whenever one collects a whole blood, one should separate serum within 2 hours of collection. Since IGF-1 does not follow any circadian rhythm and is in bound form, the collection can be done any time of the day. IGF-1 is stable at room temperature, and it can also be stored at -20 degrees for weeks together. The various assays that are used are immune assays and liquid chromatography, tandem mass spectroscopy. The most commonly available assays that are done in most hospitals are immune assays, which are antibody based. But ideally, ideally one should do a liquid chromatography tandem mass spectroscopy. Now the assays measure either total IGF-1 levels or free IGF-1 levels. So let's see what is better. Total IGF-1 levels, they measure the ternary complex, which contributes to around 98 to 99% of the IGF-1. Free IGF-1 is a biologically active form, and it exists in the concentration of 0.95% to 2.2%. Free IGF-1 assays are immunoradiometric assays, and they require multiple staging and is a complicated process. So ideally speaking, free IGF-1 assays would be better to do to know the biologically active form of IGF-1s, but normally we do total IGF-1s. So let's understand from few studies. This was a study done by Joule et al., where he compared free IGF-1 levels in 1,430 patients, and he saw that the sensitivity and specificity of free as well as total IGF-1 was nearly same, and the accuracy of the test was also nearly same. And so they concluded that the free IGF-1 does not have any superiority over total IGF-1 levels. And a similar study was also done by Hasegawa, where they also concluded that free IGF-1 is as has same efficacy as total IGF-1. So to conclude, free IGF-1 has no additional benefit over total IGF-1 level. So one can do a total IGF-1 assays instead of free IGF-1 assays as they are more complicated and tedious. So just to understand the sensitivity and specificity of total IGF-1 assays, we can see that various studies have reported sensitivities of IGF-1s ranging from 34% to around 99%, whereas the specificity of IGF-1s is more. So what happens and which conditions affect IGF-1 levels? As we have discussed previously, growth hormone and growth hormone receptor defects will cause significantly diminished growth IGF-1 levels. But various other conditions like discussed previously, like malnutrition, liver disease, severe illness, trauma also can cause low levels of IGF-1s. In addition to that, one should also keep in mind that some conditions like constitutional delay of growth and puberty can also have low IGF-1 levels, but with normal IGF-BP3s. Conditions, other comorbidities like diabetes, hypothyroidism, and can also cause low IGF-1 levels. So after understanding about the IGF-1 assays, there are some limitations that are there, which is there are no standardization available for IGF-1 assays. Recently, in 2014, WHO has published a standard IGF-1 assay, and validation of this assay has also been done in a study which involved 12 centers and 15,000 patients, and they tried to derive a normal range from birth to senescence, and they have made a reference range, but this study was done in US and Europe. Now, whether this data will be validated for Indian scenario is not known. So at present, there are no standard normative data that is available for an Indian scenario. IGF-1 BP3 also interferes with IGF-1 assays, and they will cause falsely low values. So removal of this IGF BP3s is required prior to processing the IGF-1 levels. And as we discussed previously, various factors also affect the IGF-1 assays and hence has to be kept in mind. And IGF-1 levels tend to be normal or on the lower normal side in patients who have acquired growth hormone deficiency due to malignancies or in adult GHDs. So all these limitations are there for IGF-1 assays. One more important role IGF-1 plays is in monitoring. So what is the exact role of IGF-1 in monitoring of growth hormone therapy? This is well explained by the study done by Lanes, where they have seen whether IGF-1 levels are affected with growth hormone and what is the significance of improvement in IGF-1 levels. In this, we can see that at 6 months, there was significant improvement in IGF-1 levels, but at 12 months, there was not much significant improvement. So they concluded that though IGF-1 levels do improve with growth hormone, but they do not play any role in monitoring the response. And similar response was seen in this study, and they concluded that IGF-1 levels are important for monitoring of growth hormone therapy to assess compliance, safety in these patients, and not to assess the response to therapy. And it also plays an important role in patients with growth hormone insensitivity to see whether they do respond to growth hormone or not. There are few studies which also talk about IGF-based dosing. This study was done by Cohen et al., which showed that if the IGF-based dosing was used, there was a significant improvement in height in these patients when the target was to achieve a high IGF SDS of 0. But this is not recommended as of now. Coming to the risk factors, as we have discussed previously, high IGF-1 levels are associated with increased risk of malignancies, which has been well documented in adult growth hormone deficiency patients, but this risk has not been yet documented in pediatric patients. This was a follow-up which was done in 15,000 patients in Europe, where they have detected an increased rate of neural malignancies of around 2%, which is as same as patients without growth hormone therapy. So as of now, the risk is minimal, but one should be vigilant about this risk. So Now, a Growth Hormone Research Society guidelines, which were published in 2019, still recommend that one should target IGF-1 levels not more than 2 SDS, and one should reduce the dose of growth hormone in a patient if the IGF-1 levels are more than 2 SDS in a growth hormone deficiency, if it is more than 2.5 SDS in patients of idiopathic short stature, and if it is more than 3 standard deviations in patients with Turner's syndrome. Consider, keeping this in mind, we will go ahead with IGF-BP. There are 6 types of IGF binding proteins. The IGF-BP3 is the most common, as discussed by Dr. Neha. It contributes to around 90% of the total IGF binding proteins, and it is dependent on growth hormone. This IGF-BP3 acts as a transport protein to transport IGF-1 from liver to the target sites. It also acts as a buffer as to decrease sudden release of IGF-1 and cause hypoglycemia, and also it independently acts on the cells and causes apoptosis. IGF-1 BP3 also increases with age, but the levels tend to be on the higher side and can be detected by in neonatal age group as well. As compared to IGF-1, IGF-BP3 assays are technically very simple. They do not require removal of the binding proteins prior to IGF, like in IGF-1 assays. The normal values are on the higher range, like 1 to 5 ng per ml. So there are no sensitivity issues that are encountered in IGF-BPs. They vary with age, but to a lesser extent as compared to IGF-1, and hence are preferred in children less than 3 years. They vary with nutrition also to a very less extent, and hence are preferred compared over to IGF-1. So the IGF-BP3 assays require the same serum sample and has to be processed within 2 hours of collection as IGF-1. And since IGF-BP3 also does not follow the circadian rhythm, hence the sample can be collected any time of the day. The assays that are used for measurement of IGF-BP3s are immune assays, which are also antibody based. Now the assays can measure either total IGF-1 BP or functional IGF-BPs. It would be ideal to measure functional IGF-BP3s, as total IGF-BP3s will include active as well as inactivated or fractionated IGF-BP3s. But various studies have concluded that there is no significant difference in sensitivity and specificity of total IGF-BPs and functional IGF-BPs. Hence, we do total IGF-BP levels. Just a summary of the sensitivities and specificities of IGF-BPs on assays by various studies shows that IGF-BP has more specificity compared to IGF-1s, though they are less sensitive. So to interpret the results of IGF-1 and IGF-BP3, if IGF-1 is low along with IGF-BP3 and growth hormone as discussed, is seen in growth hormone deficiency, in growth hormone resistance, STAT5B deficiency, and IGF, acid labile substance deficiency. If IGF-1 and IGF-BP3 are low with a normal or high growth hormone, it suggests growth hormone resistance syndrome. If IGF-1 is low with elevated IGF-BP3 with a normal or high growth hormone, suggests IGF-1 defect. If all the three are high, it can be seen in IGF-1 receptor defect, as well as a new mutation that is seen is paplysine 2 gene, which also presents with subtle short stature and dysmorphism with high IGF-1, IGF-BP3 and growth hormone. So now let's see what are the recommendations. This is a recent guideline published by a Growth Hormone Research Society in 2019, which recommends that IGF-1 and IGF-BP3 should be used as a screening test in a child suspected to have a pathological short stature. Any IGF-1 which is less for the child with growth failure is suggestive of a diagnosis of growth hormone deficiency. When I say less than 2 standard deviations for the age and gender. Any IGF-1 levels at any time, if they are more than 0 SDS, makes the diagnosis of growth hormone deficiency unlikely. It also recommends that IGF-BP3 is considered to be a more reliable biomarker than IGF-1 in children less than 3 years. And we all know the reason why, as we have discussed previously. So, but what happens in a country like India, where the resources are limited and there are various financial issues which parents face? Then, if we know the cost of IGF-1 is around 5,000 to 6,000, which is same as the cost of doing a growth hormone stimulation test in India. And as discussed previously, there are significant overlap of IGF values between a normal and a growth hormone deficient child. And IGF-1 levels are affected by various factors. And the guideline also recommends that in a child who has low IGF-1, growth hormone deficiency should be confirmed by growth hormone stimulation test. Considering all these factors, whether doing IGF-1 as a screening test or in India is a doubtful, is a question. So to conclude, one should know that IGF-1, IGF-BP3 and acid labile substance are growth hormone dependent peptides. There are various issues that have to be kept in mind, and like age, gender and assay issues. Each of them has a variable sensitivity and specificity, and all of them require confirmation with a growth hormone stimulation test to confirm a diagnosis of growth hormone deficiency. So in a resource limited setting like India, one would recommend doing a growth hormone stimulation test instead of doing an IGF-1 or IGF-BP3 if the patients are not affording. Thank you.
Thanks a lot, Sajali. I think this was a very nice presentation and you looked into real evidences with regards to IGF-1 and BP3. Maybe you can stop the screen sharing now.
Yes, sir.
So I think the big message probably which is coming out of it, that there are some Indian data which is emerging. Dr. Meena Desai's data was there. That's quite now in terms of timing, it's reasonably old. It doesn't give too much information about that. The key issue is that you should select your patients in which IGF-1 may have a role. So if you have somebody who has got a underlying malformation, who has got that MRI finding, who has received maybe let's say craniosurgery, who has a craniopharyngioma, in that if you document low IGF-1, that's enough. You don't need to do anything else. Second, if you have an obese child, in an obese child, if your IGF-1 is low, then you are pretty much more certain that this is more likely to be a growth hormone deficiency, because we've discussed that growth hormone levels may be unreliable. So I would definitely agree with you that there is no role of routine IGF-1 as a screening test. So that would be a total waste of money. And in our own guidelines and in our own algorithm that we are developing, we're talking about IGF-1 at the end in terms of differentiating deficiency versus insensitivity. So there will be specific situations in our setup which we'll like to do IGF-1, but not on a continuous basis. It definitely will have a role in terms of monitoring, and that we'll discuss about when we talk about GH therapy and other aspects as well. So I think this was a very nicely put presentation, and thanks a lot. And if there are any questions, we'll take it forward. There's one question which has come from Dr. Sanjay. Is there any role of IGF-1 therapy in adults to increase their musculature? Now that's a different thing altogether. But what do you think, Sajali? Will you like to give IGF-1 to adults?
So no.
Definitely
because
not.
The risk is more compared
because
to
they are so the reason why the body has done a somatopause is that it does not want to develop tumors. So basically, if you've got too high growth hormone levels, it will cause, there will be no growth, there will be more growth of tumors. So that's why there is a very clear issue that acromegaly causes all that colonic adenomas and carcinomas and many other associations. So do not do it when it is not required. So IGF-1 therapy will be really, really harmful in that setting in terms of any benefits. So I think that's pretty much the answer. Thanks again, Sajali, for a wonderful talk. And we'll carry forward with regards to the other, continue on the talk from there. So, so we have already discussed now in terms of a lot of issues with regards to the overall assessment of growth hormone and in terms of evaluation, in terms of the growth hormone peptide. We'll now move forward in terms of further evaluation. So if we know that there is IGF-1 deficiency and we discussed there is no very easy way to do that, if you have a documented low IGF-1 or IGF-BP3 in an appropriate nutritional setting, the next question is it growth hormone deficiency or insensitivity? To answer that question, we will obviously look into clinical parameters as well. So we've got two children, very short, who have a very short height, and one has got a growth hormone level which is very low, and one on the right has got a growth hormone level which is very high. So that's why a lot of people ask me, why do you do a growth hormone stimulation test? If you have a short child with a plump child who has got micropenis, undescended testes, which has got a protuberant belly, why do you need to do a growth hormone stimulation test? The answer lies in this slide. You've got on one side, the left-hand side, you've got a child who has got growth hormone deficiency, and on the right, you have a growth hormone insensitivity. And that child, if you give growth hormone, you will be wasting a lot of money. So if you look at those two children, I think this will be very easy to see that there are differences which you can make out. Both are short, both are plump, both have abdominal obesity, both have undescended testes, and both have micropenis. But the similarity ends there. What you see is that this is a typical cherubic facies on your left-hand side. This is what we talk about growth hormone. But for IGF deficiency, they look a bit sick. In that sense, they're not looking well overall as the GH children will. They have sparse hair, there is frontal bossing, shallow orbit, and hypoplastic nasal bridge. So if you are quite tuned to evaluating, you can identify that this looks more like a growth hormone insensitivity in that regards. And if you do, you may just do a basal growth hormone, and if the basal growth hormone is more than 5, you can start thinking of growth hormone insensitivity. But that's a different situation. You have to evaluate for all other parameters also in that regards. So now that brings us to in terms of evaluation of growth hormone. And as we know, that growth hormone evaluation is very challenging, especially because of the pulsatile secretion. So basal growth hormone, as I said, may be only indicated in this sort of situation where you have a classic presentation of growth hormone insensitivity. The next question is how to do a dynamic test, how to order, how to assess and manage. And for that, we have got Dr. Riddhi, who will be talking about that particular topic of the dynamic test. So Dr. Riddhi, you can now come up and start your presentation. Yeah, you can start. Your screen is visible.
Okay, sir. Okay, so thank you, sir. Good afternoon to all. So today I am going to discuss about the dynamic tests which are used for assessment of the growth hormone IGF-1 axis. So as Sajili has already discussed that there is no role of the growth hormone dependent peptide, that is IGF-1 and IGF-BP3, in diagnosing the growth hormone deficiency. And as the growth hormone is secreted in pulsatile manner, there is no role of the basal growth hormone for diagnosing growth hormone deficiency. So there are various stimulating agent which is used to enhances the endogenous growth hormone secretion. And if there is no response to this stimulating agent, then it suggests or confirm the diagnosis of the growth hormone deficiency. So gold standard test which is initially devised for diagnosing growth hormone deficiency was insulin tolerance test, but nowadays it is not used in most institutions because of the dangerous side effect of the severe hypoglycemia that is associated with insulin tolerance test. So nowadays in most institutions, the glucagon and clonidine stimulation test which are commonly used, we are also using clonidine stimulation test in our center. And before doing growth hormone stimulation test, it is essential to rule out cortisol excess and thyroxine deficiency, because both of these conditions associated with reduced growth hormone production as well as action, the resulting in false diagnosis of growth hormone deficiency. So it should be ruled out before doing growth hormone stimulation test. And as there is role of the sex steroid both in boys and girls for growth hormone production as well as action during the puberty, it is essential to do priming in both boys and girls in peripubertal year before doing growth hormone stimulation test to avoid the false positive diagnosis of growth hormone deficiency. And peak stimulated level of growth hormone, if it is less than 5, it suggests complete growth hormone deficiency, while level between 5 to 10 suggests partial growth hormone deficiency, and level more than 10 indicates the adequate response to growth hormone stimulation. Now, as already discussed in Dr. Neha's talk, that if there is a defect in growth hormone axon or IGF-1 axon, that is, that condition is known as growth hormone insensitivity. This can be diagnosed with using the IGF-1 generation test, which we will discuss in subsequent slide. So growth hormone stimulation test routinely used protocol is it should be done in morning after overnight fast of at least 8 to 10 hours. And priming is must in prepubertal boys and girls. The age which is defined in the various guidelines for doing priming is different, but ideally it should be done in prepubertal boys and girls before 10 years in girls and before 11 years in boys, as Endocrine Society guidelines suggest, and before 8 years in girls and 10 years in boys. That is the various different guidelines suggest. And priming should be done with 17 beta estradiol, that is at a dose of 2 mg on 2 successive days prior to the test in both boys and girls, or alternatively testosterone is used at a dose of 100 milligram intramuscularly 5 to 7 days prior to the test in boys. The stimulating agent which is used are the clonidine, which is used at dose of 5 microgram per kilogram, and maximum dose is 200 microgram. One tablet is 100 microgram, so the maximum dose is 2 tablet. Insulin is 0.1 unit per kg, and glucagon is given at a dose of 30 microgram per kilogram. Now the time point at which the sample of the growth hormone is collected is different for different stimulating agent. For clonidine and glucagon, it is collected every half an hourly for next 2 hours. And if peak stimulated growth hormone level is less than 5, it suggests complete growth hormone deficiency. Ideally, 2 tests should be done before labeling someone as growth hormone deficiency, because of there is variability in terms of growth hormone assay as well as growth hormone stimulation test. And there are various pitfalls of growth hormone stimulation test. The cutoff which is given in the various guidelines as well as recommendation and consensus, that are arbitrary cutoff, that are not based on actual height response to growth hormone. And there is also variability of the various protocols as well as various growth hormone assays. And even normal growing healthy individual also fail to respond growth hormone stimulation. So it is recommended to do the 2 stimulation test before doing before diagnosing growth hormone deficiency. And as we have discussed that the delayed puberty as well as obesity which interfere with the growth hormone secretion, we should keep both this condition, delayed puberty and obesity, in mind before interpreting growth hormone stimulation test and before starting growth hormone. It should be done only if there is a clinical condition suggestive, like if there is height SDS less than -3 or height velocity SDS below -2, and there is delayed bone age, or there are clinical parameters suggestive of growth hormone deficiency. And we have already discussed that 2 tests should be done before doing the before diagnosing growth hormone deficiency. So now there are plenty of the protocols and guidelines are available for growth hormone deficiency diagnosis. And in Europe, recently one audit is done for the currently available national guidelines. And what they have found, there is huge variability in terms of pre-test condition before doing growth hormone stimulation test. Height SDS cutoff is almost same in various guidelines, but there is huge variability in terms of some recommend use of IGF-1 before doing growth hormone stimulation test, some do not recommend it, some recommend monitoring of the height velocity. The height velocity cutoff is also different in different recommendation. And what they have found, that the protocol which is used for growth hormone stimulation and the stimulating agent which is also different in different guidelines. The cutoff of growth hormone is also differently used in various national guidelines. So there is huge variability in terms of diagnosing growth hormone deficiency with use of the growth hormone stimulation test. There are usually variable protocols are available. So this audit concluded that we should use uniform protocol for diagnosing growth hormone stimulation test to avoid the false positive diagnosis and unnecessary treatment of the growth hormone deficiency. Nowadays, the guidelines which is available for diagnosing growth hormone deficiency are clear-cut in terms of the recommendation that this Pediatric Endocrine Society guidelines suggest that we can diagnose growth hormone deficiency without doing growth hormone stimulation test if there are typical oxological criteria, that is height SDS below -3 and height velocity SDS below -1.5, associated with hypothalamic pituitary defect like major congenital malformation in form of hypoplastic anterior pituitary, ectopic posterior pituitary and interrupted stroke, or there is evidence of tumor or history of the radiation to the brain, and associated one additional anterior pituitary hormone defect where we can skip the growth hormone stimulation test and we can diagnose growth hormone deficiency without it. It also recommended that growth hormone deficiency should not be based on the single biochemical criteria of poor response to growth hormone stimulation. It should be based on combination of clinical, biochemical as well as radiological parameter. And growth hormone assays should be done in the laboratories which are using the standard somatotropin standard, that is recommended in 2006 and 2011 consensus, to avoid the variability of the results. And priming is suggested by Pediatric Endocrine Society guideline in prepubertal boys older than 11 years and girls older than 10 years, and their predicted adult height in target height range. This is very, very much important criteria, because by doing priming, which we are our main purpose is to exclude the constitutional delay of growth and puberty. So if their predicted adult height in target height range, there is possibility that CDGP can be one possibility. So it should priming is must in such individuals before doing growth hormone stimulation test. The Growth Hormone Research Society guideline, which is recently devised in 2019, also suggested the use of two provocative stimuli for diagnosing growth hormone stimulation test. But at the same time, they have also discussed that we can skip the second stimulation test if there is a high index of clinical suspicious for growth hormone deficiency, where single test may also suffice. And with the availability of the newer growth hormone assays that are based on monoclonal antibody, growth hormone measurement is lower as compared to older immunoassay based testing. So nowadays the cutoff of growth hormone is reduced from standard 10 to 7 in this newer guideline. And they have also discussed that even without growth hormone stimulation test, we can start growth hormone in the conditions where there is significant short stature, delayed bone age, poor growth velocity, very low IGF-1 level, and a suggested MRI abnormality of the hypothalamo-pituitary, where we can start growth hormone even irrespective of level of growth hormone. And they have also discussed that the peak stimulated growth hormone level is inversely correlated with BMI. As Dr. Anurag has already discussed, that the BMI is growth hormone sensitive state, so where we can falsely diagnose obesity. So this obesity should always be kept in mind before diagnosing growth hormone deficiency, where we should be liberal before diagnosing growth hormone deficiency and starting growth hormone. Now this newer agent that is already discussed in pathophysiology part by Sir, that mesimorelin, which is ghrelin receptor agonist. Sir has discussed that ghrelin is the agent which is potent stimulator of the growth hormone secretion, and this agent can be given orally. This is rapidly absorbed and it has potent growth hormone stimulating property. So it can be used for growth hormone stimulation test instead of insulin intolerance or other provocating agent which we have discussed earlier. And in this particular validation paper in adult GHD, they have found that at cutoff of 5.1, where there is a higher correlation between the peak GH by mesimorelin and peak GH by insulin tolerance test. So it can be used in adult population. And at cutoff of 5.1 nanogram per ml after giving mesimorelin, the growth hormone growth hormone cutoff of 5.1 after giving mesopelin has sensitivity of 96% and specificity of 92%. So it is a very good agent, and it is now being studied in pediatric population also. Primary IGF-1 deficiency, the diagnosis is very difficult. There are multiple criteria that can be used. Basal growth hormone, though it is very crude parameter, but if it is more than 5 nanogram per ml, it usually suggests the possibility of the growth hormone insensitivity. Or we can use IGF-1 generation test, where growth hormone is given at a dose of 25 microgram per kilogram per day for 5 consecutive days, and IGF-1 level is measured at baseline as well as 7 days after the growth hormone injection. If rise in IGF-1 level is less than 15 nanogram per ml, it suggests the primary IGF-1 deficiency or growth hormone insensitivity. Though this test also has limitation, and studies have shown that subnormal response is also seen in healthy individual also. So it should be done only if there is high index of clinical suspicious is there. Growth hormone binding protein, which is very good test, which should be done before doing growth genetic testing, because it is one of the most common cause of the growth hormone insensitivity. And this growth hormone binding protein is proteolytic product of the extracellular domain of growth hormone receptor. If it is very low or undetectable in circulation, it suggests growth hormone receptor defect, and it is confirmatory of primary IGF-1 deficiency because of growth hormone receptor defect. And finally, we can do genetic analysis for known genetic problem that is already discussed for primary IGF-1 deficiency, which is confirmatory of primary IGF-1 deficiency. Thank you.
Riddhi, thanks a lot for this wonderful presentation. So you can stop the screen sharing now. There are a couple of questions which are there. Dr. Sanjay is asking from Sitamarhi about what is the rationale of glucagon suppression test, glucagon stimulation test.
Okay, so the when we give glucagon, it initially causes rise in blood sugar, but after there is rebound hypoglycemia. So after at the rebound hypoglycemia, there is, if we collect the sample of growth hormone, if it is low, it suggests the growth hormone deficiency.
Yeah, so the mechanism is very interesting, and this is also important because glucagon also has a risk of hypoglycemia, which may be delayed. So we used to do it routinely in Australia. The test is longer duration, 180-minute duration, and the sample required are more glucose monitoring for longer periods. So it is a bit more complicated than clonidine. I would say clonidine is a pretty good test in terms of the response, but if you want to measure cortisol, glucagon will be a good test to start off, especially in younger children. Also, glucagon is a better test in that regards. Insulin, many people are doing it, but we are a bit cautious because of the risk of hypoglycemia. And now, since we are basically going ahead in terms of overall, in terms of going away from the numbers, maybe it is not that important. So there are a few other questions which have come up. One is from Dr. Sivan Arul Selvan. 2 standard deviation values for IGF-1, yeah, that's available. So I think that's pretty much there. So when the reports come from many of these labs, they tell you what is the exactly standard deviation score. But the question is, which references are they talking about? So they are not Indian references, they are the US references. So you have to be cautious about that. Another question, should we keep the patient on maintenance IV normal saline when doing chlorine test? Riddhi, what do you think?
No, routine not required. We should monitor blood pressure. If it is go below the 50th centile, blood pressure below 5 and 8, then we should give a normal saline bolus or the maintenance IV.
And it is not required, maybe 1 to 2% will require it basically. The next question again from Dr. Sivan is insulin test for GHD. The zero sample is time of the insulin injection or from the onset of hypoglycemia?
No, it should be collected at the onset of hypoglycemia.
No, the first sample can actually be at the baseline sample, so it doesn't matter. So we are looking at the baseline sample that ideally should be a non-stress sample. And then once you give the injection, then you start measuring once your hypoglycemia happens from there. Dr. Pias is asking, what is the age for Indian children to do sex steroid priming? What do you think, Riddhi?
So we are following the protocol of that is suggested by Pediatric Endocrine Society guidelines. So 10 years for girls and 11 years for boys.
I think what we need to understand is that what do you mean by this priming? What do we aim? The aim is basically to avoid those children with CDGP who are misdiagnosed as growth hormone deficiency. So they are the time when puberty should have happened. So 9 and 11 is a reasonable age to think of it. The second is they should not be very short. If they are really, really short, like their height SDS is -3.4, you do not need to do a priming. And third, they should be, the predicted height should be in the normal range. So if all those criteria, in a way, if the height SDS of 1.8 is less than -2, is more than -2, then you have to start thinking of priming. I think that will be more relevant, because if somebody is very clear cut, if your pretest probability of GHD is high, you don't need to do priming. That's a big message, I think, there. So I think it was a good talk overall. Thanks a lot, Riddhi, for covering this very important topic. We will now move forward with regards to the other aspects of further approach to a patient with IGF deficiency. So as we discussed now, that we already know the algorithm in that regard as to how we evaluate. We know how to do growth hormone, how to do IGF-1. So if, as Sanjay had said, that if your growth hormone is low, IGF-1 is low, this is GHD. Now, this basically is very, very most common cases will come like this. If your growth hormone is high and your IGF-1 is low, this means there's a growth hormone resistance, then in that case it is insensitivity. You can do a growth hormone binding protein, which will be low in growth hormone resistance. Now, if your growth hormone and IGF-1 both are high, it means a primary IGF resistance. This is a rare situation. So those who have got a low level of IGF-1 with a normal growth hormone, do a growth hormone binding protein and a STAT5B genetic study. And if all that is normal, go for IGF-1 gene. And if it's high, look for the receptor issues on that regard. Now, once you diagnose, the next step is evaluation. And in that regards, look at pointers. So if you have rash, seborrhea, hepatomegaly, ear discharge, polyuria, polydipsia, think of histiocytosis. If there is a teeth, a ear, a eye, or spine abnormality, think of a congenital cause. If there is features of raised ICT, headache, vomiting, think of a mast lesion. There is a spine abnormality, very rare, you can have a LHX3 mutation. Look at eyes. If there is a visual problem, absent blink response, there is a roving nystagmus, think of a septo-optic dysplasia. And if you have ptosis, third nerve, sixth nerve palsy, this could be a pituitary apoplexy in that regards. Very importantly, anybody whom you're diagnosing with isolated growth hormone deficiency, please do a MRI. This is absolutely essential. It has to be a T1 coronal and sagittal, which is a thin slice MRI, 3 mm MRI. Look at the different parts of the pituitary. And what you can see here is that this is the hypothalamus, from which we have got the chiasma, we've got the pituitary and the stalk. So you have to look at the anterior pituitary, the posterior pituitary, the stalk. And this is very, very important to really identify that. Ideally, you should do a contrast enhanced imaging and look for T2 images for hemorrhage. Now, very important thing to remember in children is that many of these infiltrative disorders like germinoma, hypophysitis may present just with stalk thickening. So look at the stalk. It should be really thin. If the stalk is thicker than basilar artery, start thinking of a possibility of abnormality with regards to a germinoma. Look for posterior pituitary, whether it's there in the right location, and what is the size of the pituitary in that regard. Now, you can find this finding, which is ectopic posterior pituitary, hypoplastic anterior pituitary, and a hypoplastic stalk or the arch. So this is basically a pituitary stalk interruption syndrome. You can have stalk thickening, which basically suggests a hypophysitis or a craniopharyngioma. You can have a large lesion coming from up to down with solid cystic components with calcification, which is craniopharyngioma. You can have corporal callosal alveolis suggesting septo-optic dysplasia. The other abnormalities you can see is a rat case cyst, a cystic lesion which is abutting the pituitary, or you can have a germinoma in which there is a synchronous lesion in the pineal body as well as the cellular regions. So these are the things we have to be really wary of. Craniopharyngioma is very, very important in that setting. Now, once you talk about growth hormone insensitivity, you have to look at few things. So birth weight would be compromised only if there is a IGF deficiency, there's an IGF gene defect or a receptor defect. You will find this to be very severe in most cases, much more severe than GHD. IGF-1 levels will be low in all except the IGF-1 receptor levels. And as I said, GHBP and Riddhi also really nicely pointed out, The growth hormone binding protein levels, if they are low, they are suggestive of a growth hormone extracellular domain defect. So this is how you will classify from that. So we now start off with cases. So Pratik, if you can come forward. Yeah, you can switch on your presentation as well. So you can start off with the case.
So a 16-year-old girl with history of delayed puberty and growth failure at a height of 144 centimeters and a weight of 41. Now here LH, FSH and estradiol were done. LH was 0.1, FSH 0.3 and estradiol 10. Now somebody did a prolactin at which came 32 and cortisol came 24. Now here somebody did a peak GH and the peak GH was 1.1 nanogram per ml.
What do you think, Pratik? Here we've got low LH, low FSH, low cortisol, low growth hormone. This looks like a MPHD. What do you think is the site? Is it a pituitary lesion or is it a hypothalamic lesion?
Now this looks more like a pituitary lesion because everything is less. It could be hypothalamic as well because prolactin is slightly raised. We can think that way.
Yeah, so this is a very, very important thing. So the first thing you will look at in a pituitary function is to look at prolactin. Prolactin is the distinguishing factor between a hypothalamic lesion where the levels will be high versus the pituitary lesion where the levels will be low in that situation. And what we find here is that this is the classical rat case cyst, which is causing this hypothalamic compression as well. So again, a big message there that always look at prolactin. If it is a pituitary lesion, the prolactin will be low. While if it's a hypothalamic lesion, your dopamine inhibition goes down and prolactin becomes high in that setting. Second case, Pratik.
So here we have a 27-year-old boy who has growth failure, height is short at 132 centimeters, TV is only 2, pubic hair stage 1. Now we have TSH, which is low, FT4, which is low. And somebody did growth hormone stimulation, which ultimately a very poor result, and LH was also undetectable.
So what do you think about this 27-year-old boy? This seems to be a hugely affected child. What do you think? This could be a congenital MPHD or an acquired MPHD?
So the thing is, he has a TV of 2. If it was acquired, I would expect a larger testicular volume and no pubic hair. So I feel this is a congenital MPHD.
So what we find here is that what do you see on the MRI, Pratik?
So MRI, I could see just an empty cella. I could not appreciate anything else. So as it was shown here.
So this was an empty cell. So this would have been destroyed earlier, and that's why he presented now with severe MPHD. Now next case, Pratik.
So a 12-year-old boy with growth failure, FT4 is 3.2, TSH is low. So a low TSH with FT4 low, peak growth hormone is also low at 1 nanogram per ml. Cortisol is low and ACTH is low as well. LH, FSH, testo, everything is low. So now the question comes, is it pituitary versus hypothalamic?
So you will do which test will help it out?
So first of all, a prolactin, which will be easily differentiate between the two.
So now the prolactin is 1.2. It means that this is a pituitary lesion. So as compared to the first case where we had a similar picture with a highish prolactin, that was a hypothalamic lesion. This is a cellular lesion in that regard. So I think this is a big message from that. What about this 18-year-old boy? What do you think?
An 18-year-old boy who presented with history of headache, visual field effects. Prolactin came very high, 440. Growth hormone stimulation is showing 1.1, FT4 is also low. So here, even in the imaging, we can clearly see that there is a mass which is affecting the cellular as well as the supracellular region. So now I would like to forward.
So is it a cellular mass going up or is it a supracellular mass coming down, which is a big question?
As we can see the constriction, which is very clear, it looks like a cellular mass which is going towards the supracellular extension.
So this is typically a figure of 8 appearance or a snowman appearance, which basically happens with a pituitary macroadenoma. Because of the diaphragm cella, you're just going through, squeezing throughout and making like that. While if it's a supracellular lesion, like we saw with the craniopharyngioma, it just came down just like this. So this was a pituitary macroadenoma, a functional lesion which causes compression of the growth hormone in this situation. What about this child, 9-year-old girl with growth failure?
Yeah, so 9-year-old girl, very short, height of 114 centimeters. IGF-1 level came low at 44. So now basal growth hormone came high, which is 5.4 nanogram, not high, but it is adequate. But what was seen in this individual was that the albumin was low, ALT was slightly raised. So whether
Yeah. So
IGF-1 straight away was a correct decision to do. It was, we had to see, because IGF-1 low can be there in many situations such as undernutrition, liver disease, etc.
So the big message is that do not do random IGF-1 that can cause more confusion. This child was malnourished. She had underlying liver disease, and that will falsely give you a lowish IGF-1, and you will label them as a growth hormone insensitivity in that situation. What about the 6-year-old boy with growth failure?
Yeah. So 6-year-old boy, normal birth weight, but he now presented with short stature at just 92 centimeters. Basal GH is 8, IGF is 40. So now we have basal GH being normal, but IGF being low, suggestive of a growth hormone resistance. So now we have basically, now we went to look at growth hormone binding protein levels, which was undetectable, suggestive of a growth hormone binding protein deficiency.
So this is the classical Laron syndrome, which is the extracellular domain deficiency of the growth hormone receptor, which is very important. So GHBP plays an important role. Before you do a lot of these genetic tests, do a GHBP level in the beginning. What about the 7-year-old girl with growth failure?
So we have a 7-year-old girl, normal birth weight, height is short at 95 centimeters. Now this is different from the previous case. Here we have high basal growth hormone levels and low IGF-1 levels. On further asking, we found that there was history of recurrent infections. So we have growth hormone resistance with history of recurrent infections. I would think of STAT5B deficiency.
Yeah. So again, if you go back to our table, you will find a lot of these pointers to diagnosis, which will help out in this case, which we saw. Now, 3-year-old girl.
So a 3-year-old girl, severe short stage, severe growth failure. What is important here is the birth weight is very low. It is 1.4 kgs only. So
what is excluded here?
Sorry, sir?
What causes of IGF deficiency are excluded in this
So
case?
IGF resistance and IGF deficiency can cause growth hormone receptor defects can cause these issues.
Yeah.
IGF,
So we are not talking about GHD. We are not talking about Laron syndrome. We are not talking about STAT5B. It has got a low birth weight. This is very, very important in this setting. So now basal GH is high. IGF-1 is 130. What do you think?
So we have a basal GH high, IGF is also high. So now this is suggestive of either a receptor defect or gene defect. So which is, here it is receptor defect.
So I think this is a big message that your onset of growth failure is very important. If your onset of growth failure is prenatal, you're only dealing with IGF-1 receptor defect or an IGF gene defect, which is in the situation there. Now this 10-year-old girl, a boy.
So now we have a 10-year-old boy with growth failure, height is 100 centimeters. Weight is 13 kgs. Initial tests were normal. FT4 is normal. Here we have basal whole growth hormone is low at 0.2 and IGF is low at 70. Now the question is, he was started on growth hormone at 30 microgram per kg per day, but then the response was only 2 centimeters per year. So now we need to see why. Is it a correct step to take to start on growth hormone?
So I think the big message here is that we just did a basal growth hormone, which is of no value as that. You got IGF deficiency, but you have to do a stimulation test. So in this case, if we did a stimulation test, which would be normal, which was missed in this case, and that caused a lot of confusion in this setting. So I think thanks, Pratik, for the case discussion. We will now move forward to the third component of our discussion, which is about therapeutics. Before that, we will see if there are any questions. We will take any questions on diagnostic part, and then we'll finish off with the therapeutics part. So I think there are a few questions which are there. Why GST cutoff is low, sir, as we are stimulating his cutoff? Why not high? Okay. So this is a very, very interesting question from Dr. Pankaj about the growth hormone cutoff. So basically, if you talk about growth hormone levels, somebody will do growth hormone levels are pretty low in most cases, and we only have a stimulation which happens in between. So the basic principle of endocrinology is that if you have deficiency, you stimulate it. If you have high levels, you suppress it. So in this case, we are using a level which has to be lower than particular level. Every child should have a level above 10 or whatever, 10 or 7 or whatever cutoff you want to use when in a normal situation when you do a stimulation test. If you are not able to mount that response, it means that there is a deficiency in that regards. So I think that was a good question to look at. We will now probably move forward towards the therapeutic aspect of our talk. And so once we reach a diagnosis, it becomes important to really go forward with regards to the treatment part, and the various treatment options which are available are essential to understand and manage. So we again like to thank Genotropin for supporting this program. IGF deficiency management, basically, we've got options in terms of using either the growth hormone or the IGF-1 level. Growth hormone therapy is recommended for GHD, while IGF-1 therapy is recommended for either growth hormone insensitivity, which is congenital, or acquired in the setting of an anti-growth hormone antibody with GHD1A. Now, growth hormone therapy has been used for over 60 years now. It was initially pituitary derived, which was associated with the development of the prion disease, for which it was discontinued. And subsequently from that, we had the recombinant GH for the last 35 years, which has been available. And since then, it has been approved for a number of conditions, starting from chronic kidney disease to Turner syndrome to the development of long-acting GH, now Metabolic Syndrome, SGA, Shocks deficiency, idiopathic short stature. So the whole spectrum has expanded over time. And now we'll discuss a bit about how different formulations and different types of growth hormone are used in different conditions with what response. So very important to remember that growth hormone preparations are available in a liquid form, in a freeze-dried form. They are also available as a powdered form for the biosimilars. Biosimilars are products which are similar in terms of structure, but they are produced using a different technique. And we also have a long-acting preparation, also IGF-1, which is available in our setting. Now, the major basis which I'm using today is the guideline from the Pediatric Endocrine Society, which really talks very rationally in terms of therapy. The key aspects are that your first thing is to look at oxology, and we've discussed it in detail, that you should be short, or not growing at all to do a growth hormone test. And if your level is less than 5, you become complete and partial between 5 to 10. Now, very importantly, as Riddhi has already discussed, if the IGF-1 levels are low in the setting of a CNS malformation, in the setting of radiation, in the setting of imaging findings, you do not need to do a growth hormone stimulation test in that regard. Dose we already discussed is that we tend to use lowish dose in children, maybe around 25. The US dose is nearly double. They talk about 45 to 50. Then the dose may increase on puberty, but this is a very debatable issue, and the guidelines do not suggest to routinely increase the dose during puberty. And then once we are talking about the bone growth, we come back to 25, and then the dose comes down. Men around 200, women 300 because of the estrogen effect, and finally in elderly, if we are treating, it's around 100 micrograms per day in that regard. Very importantly, we need to remember that everybody doesn't have the same sensitivity. Somebody who has got a lower level of growth hormone may respond well to therapy, and therefore we talk about severe GHD like malformations, like genetic defects, starting around 15 to 20 microgram per kg per day, because they may have problems at a higher dose. Mild GHD, you start off with a higher dose, and at puberty, you may theoretically go up to 45, although it is not essential. Only if the child is short during puberty should you think about that. Now, very important discussion which was always there, whether you should use a body surface area-based dosing or a weight-based dosing. Now, most people say they are pretty much similar, and you tend to have lower response if you use a PSA-based dosing. But definitely, if somebody is really obese, you have a 90 kg child, and you don't want to give them 9 units of growth hormone, maybe a PSA-based dosing will be better in that situation. Now, the growth hormone responsiveness will depend upon a number of factors. A big factor is the level of growth hormone. So it's very evident. The more severe, the better the response. Taller the parents, better the response. Higher the dose, better the response, but there is a ceiling. So you cannot say, okay, 25 is this, 50 is this, and 100 will be this. No, there will be a ceiling effect which will come up. So that's why this talk about 25, 50 seems to be a reasonable range in terms of growth hormone therapy. And earlier treatment is better. If you have to treat somebody with growth hormone, treat at a younger age. You will get better response, and the cost will be less because the weight is less in that situation. Now, one very interesting study which looked at is whether we can really use lower doses in somebody who has got a better height. And this basically comes out from all the prediction models, which we'll discuss about, particularly the Pfizer's prediction model, which is very reliable in that setting. And what it says is that somebody who is with less than 1.2 standard deviation score below, you can actually use a lower dose of growth hormone to get a response. And what they say is that once you reach the catch-up, you can actually cut down the dose. So this is a good way. You are basically trailing, you are behind in the race. A student is not doing it academically well. You push him for some time and then he catches up. So you may need to give a good dose in the beginning, and then after that loading dose, like some people used to say, let's say the insulin infusion, you load and then give the dose. This is the same corollary, that you give a higher dose of GH in the initial phase and then you stabilize at that point of time. Now there is a huge variation in response. Same individual will respond very well, the other may not to the same dose, and this is a major issue of thing. And 80%, most models are able to predict around 70 to 80% of this variation, and this may assist responsiveness, targeted therapy, and see whether the response is good enough or not. And therefore, there are prediction models available. Now, iGrow model is from the Pfizer KIGS database, which is basically the first large database from the Kabi study, which we've been to, and it really provides us response with regards to the prediction. Then based on this prediction, you can decide about what dose to give. If you are having too good a response, you can reduce the dose, or you can judge your responsiveness as well in that regard. Now, what happens with growth hormone therapy is that you expect an improvement of around 10 to 15 centimeters in the first year, then 8 to 10 centimeters. The height SDS typically grows by 1 to 1.5 in 2-year period. And what you expect is that there will be some increase in bone age. But if you track your height age and bone age, your height age will improve much more than the bone age. So there is some skeletal advancement, but that's not a major cause of worry in that regards. And of course, you don't want the IGF-1 levels to be very high in that situation. Now, very importantly, you have to monitor them after 1 month and then for 3 months. Tell them very clearly that you have to treat them for ideally till the final height is achieved, but at least for 2 to 3 years to get any reasonable good response in that setting. If they treat for 3 months, 6 months, it's a waste of money in that regard. Now, a very interesting study which was done by Hasi Cohen's group, which looked into the dosing of growth hormone. So we have talked about the clinical parameters and the iGrow, and this is about IGF-1 level and how you respond. They suggested that if we titrate the doses as per the IGF-1 level, you have got a better height response. But what you see on the right-hand side is just the mirror image. So while you get a good response, your dose of growth hormone is also much higher. So maybe it is just a dose effect rather than a titration effect. But having said that, it may be a good idea for somebody who is not doing well on GH to look at IGF-1 level and titrate the levels accordingly. Now, if somebody is not growing, the first thing would be to think of alternate diagnosis like celiac disease or dysplasia. Look at nutrition, look at hypothyroidism, because we all know that growth hormone will cause stimulation in terms of thyroid metabolism, so it can unmask central hypothyroidism. Look at adherence, this is important. Look at the injection technique and the possibility of development of GH antibodies, particularly in GHD type 1, where there is a severe deficiency and you give growth hormone, the antibodies will develop. So your 10-year-old child with short stature, height was very low, peak GH was low, had a normal workup and had a very good response to GH, but on follow-up, the height velocity came down to 2 centimeters per year. This indicates that there is a GH antibody which is happening, and IGF-1 therapy may be considered in this regard. This is a rare phenomena, but something which we have to keep in mind. Very importantly, adverse effects are there, but they are reasonably uncommon. It is one of the most safely given drugs. There could be some edema, benign intracranial hypertension, so there is headache, visual complaints, 1 in 4,000. So it's a rare situation. Unmasking hypothyroidism, so measure FT4 at around 3, 6, and 12 months. Slip epilepticus, so somebody is having difficulty in walking, limb, hip pain, knee pain. Think of a SCFE, which is basically a response to rapid growth. Glucose intolerance, we have never seen, a very, very rare phenomena, and tumorigenesis is a major concern. Now, if you talk about tumorigenesis, the theoretical concern comes from what we discussed in response to Dr. Sanjay's question of giving IGF-1 in elderly. High IGF-1 or high free IGF-1 may increase tumorigenesis. But what happens with growth hormone therapy? When you give growth hormone, whether it causes neoplasia or not is a question. When you give growth hormone, you have an increase in IGF-1, but along with that, your IGF-BP also increases. So your free IGF-1 is not really going high. So you're not allowing growth hormone to run amok. On the other hand, if you give IGF-1, there is no increase in IGF-BP, your free IGF-1 will really increase, and that could be a major cause of concern. So if you look at the database, there is no evidence of increase in primary cancer recurrence. There is a possibility of a slight earlier occurrence of second tumor, which may happen. And this was a big thing which was addressed in a large European cohort of around 24,000 individuals, the SAGE study, which there was a huge controversy which was there. But the final results basically show is that there is not a carcinogenic effect, but some form of cancers may happen earlier and more. And one major concern was about meningioma in that regards, and what they found that there is a slightly high risk or a very high risk of meningioma in GH after cranial radiotherapy. So we have to be cautious. I said about spinal radiotherapy because it's not going to benefit you much. It will increase your disproportion. Be very, very careful in somebody who has received cranial radiation because of meningioma. This is a big thing we have to worry about in that regards. Now, if you talk about the Pediatric Endocrine Society guidelines, they say that IGF-1 based dosing is not being proven at the moment, but this is a very controversial area. They talk about not increasing the pubertal dose of growth hormone in everybody. They do recommend that you basically treatment is mainly in terms of growth, but then you can continue treatment later on based upon the requirements of individual. And very importantly, in terms of tumorigenesis, they talk about discussing with the family and waiting for 12 months in terms of the response. What about the recent guidelines from the Growth Hormone Research Society? So they basically say that we should go more in terms of prediction algorithms because they help us in terms of treatment. They say that IGF-1 should be looked at, but they don't know what level should be there. So they said 0 is good enough, should not be more than 2 in that perspective. Very importantly, they've given us very good criteria in terms of responsiveness. So if your height SDS is not increasing by more than 0.3 in a year, that is significant in that setting. And think of other possibilities like celiac, like skeletal dysplasia, as we already discussed in our clinical setting. Now, the second most common indication for which growth hormone is given is Turner syndrome, basically which are very short around from the birth. They have got low growth, reduced pubertal spurt, and a 20 centimeter deficit in terms of final height. They have a normal IGF-1, and they also have multiple other effects. So growth failure in Turner's is because of positively insulin deficiency, of course, but also an effect of skeletal dysplasia because of a shock effect along with a growth hormone resistance. If you give a higher growth hormone dose, which is around double the dose for GHD, there will be response. Do not give a growth hormone dose, which is for GHD in Turner's. That's going to be a homeopathic dose. There will be no response in that regard. Very importantly, hypothyroidism has to be excluded. So if you talk about the Cincinnati guideline, which very well talk about growth hormone therapy in Turner's, should be given if the height is less than growth velocity, less than 50th centile, and there is a high likelihood of short stature. The dose, so this is basically moving from actually short girls to a decreased growth velocity. Now, the dose is higher, 45 to 50, and 4 years before the pubertal induction is what is ideal in that setting. Of course, in this is a pharmacological indication, no need for GH or IGF-1 testing in that regard. Now, here we talk about the PSA or the body surface area based dosing, which seem to be more reliable in terms of the cost therapy. So in Turner's, maybe body surface area based dosing is more appropriate in that context. You have to monitor in terms of growth. Remember, the growth is not as good as GHD. You expect a 1 centimeter per year increase in final height. From that, there will be a bone age advancement. There will be much higher IGF-1 levels here, and the target is to keep it less than 3. If your SDS is more, IGF is more than 3 standard deviation score, that is extremely high, which you have to be wary about in that regards. Think of complications like headache because they have a higher risk of benign intracranial hypertension, scoliosis, and limb. You have to be cautious about. So edema is common, raised ICT is common, and hypothyroidism. So all these, because your dose is much higher, will cause a greater effect in Turner syndrome as against other group of conditions in terms of GHD. You can also have a disproportionate increase in your hand size, nevi, and pancreatitis risk, which is important in that setting. The third indication is, of course, STA, which I would say is more important than Turner. It is very common, 2.5% of all newborns, 90% catch up, but 10% who do not catch up have early puberty and land up as short adults. They have same implications for preterm or SGA, plot on intrauterine chart till term and correct for the size subsequently. Now, SGA, the problem is that you have high GH in the fetal period, but then there is a combination of resistance and deficiency. And if you really give more growth hormone, you will have an improvement. They also tend to have early puberty, so you cannot wait till eternity because that's going to cause a lot of problem in that situation. Now, if you talk about the SGA consensus, all you have to do is to exclude the systemic diseases, look for nutrition, and if there is no response, consider therapy, provided there is no contraindication like Fanconi, Bloom syndrome, which can be a problem. There is no need for a GH testing. Higher dose of GH is recommended, and the response is better than Turner syndrome in terms of efficacy. Now, there are different guidelines in the US and Europe. The US people are more aggressive. They talk about 2-year treatment, even lesser height compromise. Growth velocity is not important. By European agency, talk about older children. In India, I like to probably stick to 4 to 5 years, if particularly if the child is very, very short in that regard. So keep monitoring for their growth. If they're not growing appropriately by around 4 or 5 years of age, very short, think of growth hormone in that situation. It has to be an individualized decision as per severity, and if the puberty is really advanced, think of a GnRH analog in that setting. Now, Prader-Willi syndrome, which probably is the last indication before ISS, which we'll discuss, is a hypothalamic GH defect in which you will find that there is a GHD, and because of that, the growth is less, but there is a lot of obesity. Now, this causes a lot of problem. There's also a central hypothyroidism, which has to be corrected in this setting. The guidelines of Prader-Willi is that anybody who has a genetic diagnosis of Prader-Willi syndrome, once you confirm that, you do not need a growth hormone testing and you can treat. Earlier, people were treating only for those who have growth failure, but now, if the growth velocity is less, you can consider treatment at a lower dose. Start at a very low dose because there is a risk of increasing sleep apnea and even deaths, which may happen in this setting, and then you gradually build up the dose from there. Very importantly, exclude severe obesity, diabetes, and sleep apnea, because these three can cause problems once you give growth hormone in this group of settings. It can really cause psychosis, active malignancy, of course, and respiratory infections are contraindications in that setting. Finally, what about idiopathic short stature? Now, we all know that idiopathic short stature is basically a diagnosis of exclusion. It basically means that you are short, everything is normal, workup is normal, and you have excluded the other causes. So now this is something which we have not found yet, and probably over time this ISS will become more likely to have a pathology, but till then the treatment is difficult because it is a combination of growth hormone deficiency and resistance. If you talk about the consensus guidelines, it says it's a very, very liberal guideline. Basically, anybody can be treated by these guidelines, but we have to be cautious. So height less than minus 2.25 SPS after 5 years of age with a normal evaluation, you can give them growth hormone. So this is I would say a too liberal recommendation because the treatment cost is huge. You expect $10,000 treatment for every centimeter gain. So this is something which we have to think about, counsel in detail before you even think of idiopathic short stature as a treatment modality. Growth hormone has also been considered for skeletal dysplasia, but now we have CNP receptor agonist, which may be more helpful. Steroid toxicity, hypophosphatemic rickets, and silver, which is of course like a SCA indication in that regard. So now we've discussed a lot about when to use growth hormone, which conditions we can use. We'll now move forward to the long-acting growth hormone preparation because this has been a major challenge. Parents want a lesser frequency of injection. And to discuss that, we have got Dr. Chetan Dave, who is currently working as a consultant in pediatric endocrinology at the Center of Pediatric Endocrinology and Diabetes at Rajkot. And Chetan was pretty much the backbone of our department for like 2.5 years, and now he is based there. So we'd like to invite Chetan now to carry forward from here and talk about the long-acting growth hormone, what the new advances are. Over to you, Chetan.
Thank you, Dr. Anurag, and I will say good evening to all, and I will quickly start my talk on long-acting growth hormone preparations. So I'm sharing my screen. So as Dr. Anurag rightly said that growth hormone started from cadaveric pituitary glands since 1958, but due to prion disease, it was discontinued. And due to that discontinued, we have a blessing in form of recombinant human growth hormone, which was available from 1985. So from 1985, we have lots and lots of doses of recombinant growth hormone which are available, and that's why the indications of growth hormone are increasing day by day. But as we know that growth hormone is a protein, so definitely it is only the parenteral route which is advisable. So daily, day-to-day injections for many more years is difficult to give. It is cumbersome, so compliance is a problem, and that's why we might not get that much of high potential. So since 1985, there are many attempts of developing long-acting growth hormone, and some are being used, some are in the experimental stage, some have been discontinued. So this long-acting growth hormone preparations have been made either by just modifying the structure of the growth hormone or just by adding few other molecules to the growth hormone and then injecting into the large volume so that we can prolong the action of the growth hormone, or we make that growth hormone to be released slowly into the circulation so that it lasts longer. So we have many preparations which are available, and the main is a depot form. And depot form is that the large quantity of growth hormone which is encapsulated and given subcutaneously, and it gradually releases from that injections. Other thing is polyethylene glycol mixed preparations, and this is an inert substance which does not cause anything to our system. So pegylated formulation is the other type of long-acting growth hormone. Then the attachment of growth hormone to another molecule which forms the prodrug, and from that prodrug the growth hormone gradually releases, so it will cause that growth hormone making long acting. The newer advancement in form of growth hormone fusion protein, in which growth hormone has been fused to other protein, and there is some change in the growth hormone molecule itself which causes the growth hormone to act at a bit longer. The last is non-covalent albumin binding growth hormone. As we know that in the insulin, particularly in the detemer insulin, the insulin is bound to the albumin. The similar preparation has been made in terms of growth hormone. So growth hormone is bound to albumin and it releases slowly into the circulation. So first and foremost, the first long-acting growth hormone was available after 1985, which was given monthly, which was marketed as Neutropin Depot by Genentech. But the main issue was there was a visible lump because the growth hormone dose was very large because it was given every monthly. So visible lump was there for a few weeks, as well as pain while giving injection, and that pain was lasting for many more days as well. So it was withdrawn from the market in 2004. But overall, the response to this growth hormone was equally comparable to the daily injections, but due to all these issues, it was withdrawn in 2004 from all over the world. Another depot which is currently available in the Korea as well as approved in the Europe is called LBO3002, which is by the LG Chemical, LG Life Science, and this recombinant growth hormone is been incorporated and encapsulated in the sodium hyaluronate microspheres, and there are studies which shows that this effect of this depot formulation is comparable to the daily growth hormone, and 24-month longitudinal study showed that the side effect is as comparable to the daily injections as well. But it was not used in Europe, so license was lapsed, and now it is only been used in Korea and in Korean subjects that are using without any side effect. So there are chances that this molecule, because this 24-month longitudinal study was also conducted in India by Dr. Khadilkar, there are chances that this LG preparations might come to India soon. Pegylated growth hormone in form of Gintrolan, which is the primary marketed in the China, and it is given as every 2 weekly injections. It is a 40 kilodalton hydrophilic polyethylene glycol residue, which is attached to the recombinant growth hormone. And this has been used since long in the China. And the study from the Chinese people in pediatric populations suggests that the dose of 0.2 milligram per kilogram per week for 25 weeks is as effective and as safe as the daily recombinant growth hormone. But this is only available in the China, and the Chinese people are using it since long. Another product growth hormone, which is into phase 3 trial by Ascendis Pharma, in which this growth hormone, recombinant growth hormone, has been bound to the methoxypolyethylene glycol. And with this binding, the hormone is converted into the prodrug, which is the inactive drug. And after injection, it has been detached from this MPEG and then it is activated. So it is a prodrug growth hormone, which is into phase 3 trial, and phase 3 trial, which is available on the online, it shows that annual height velocity after 1 year was greater with this group as compared to the normal daily injections in form of genotropin. So this is a very good molecule, but it will take some time to come up as the regular formulation which is available in the market. But this is the molecule we should look for. Somapacetone has got very interesting and promising prospectus. It is a molecule by Novo Nordisk. It is a recombinant growth hormone bound to the albumin via non-covalent bond, so that it is detached after giving into the injections. And phase 2 trial in pediatrics and phase 3 trials in adults has been going on, and the results shows that once weekly somapacetone in form of 0.16 milligram per kg per week provided the closest efficacy match and similar safety as compared to the normal routine daily injections of the same recombinant growth hormone. And this has been longitudinal study till 52 weeks, and this is another molecule which has showed promising results, and it will come up soon as a long acting growth hormone, but it is to be given weekly, not the twice weekly. A GH fusion protein in form of hytropin, which is by the Genexin, which is a Korean company, but the trial has been limited to the adults, and in adults they have proven in phase 2 trial that this molecule has the potential for twice monthly, that is once every 2 weekly, as compared to the daily growth hormone injections. But again, this has been limited to the adult trial. Now they are coming up with the pediatric trial as well. Another GH fusion protein in form of MOD4023 by Pfizer, it has been developed as a weekly, and that is the C-terminal peptide modified human growth hormone. So they have modified the growth hormone structure by Pfizer and OPCO from, I think, Denmark. And phase 2 trial in the pediatric confirm that it has got similar tolerability and safety profile. And there are news recently that the phase 3 trial in the pediatric population is going on, and they will come up soon again with the weekly preparations in form of GH fusion protein. Other few companies are also trying to make growth hormone, and there are preclinical stages by critical pharmaceuticals. They are developing as a depot formulation, which has to be given as every 2 weekly. Another Boulder Biotechnology is also trying weekly as a pegylated formulations in form of BBT031. And another GH fusion protein from Asterion Pharmaceuticals, they are developing as a monthly, that is 4 weekly, in form of profuse growth hormone. So these three are just in the pipeline. They have not started their clinical trial, but again, we should keep in mind that they might come in the future as well as a long-acting growth hormone. So long-acting growth hormone, the advantages are being easy to administer, because they have to be injected weekly or twice weekly. The patient will have definitely good compliance with equal efficacy as compared to the daily growth hormone injections, with comparable side effects to the daily dosing. And the molecules from Pfizer, from LG, as well as from Novo Nordisk has shown very promising results in phase 2 and phase 3 trial in children and adult as well. So we are hoping that within next few years we have long-acting growth hormone which might be available in India as well, so that we have better compliance and equally efficacious results as compared to the daily injections. So with this, I conclude my talk. Right now, we don't have any available growth hormone as per my knowledge, but soon it will be available. So over to you, Anurag, sir.
Thanks, Chetan, for a very interesting talk about the future of growth hormone therapy. And what we have seen really is that we did have the Utrophin depot for a weekly preparation, which was available with us, and which was having problems in terms of pain, in terms of swelling, in terms of a lot of these factors. So ultimately, we have to look into two things. One, the efficacy has to be as good, and the acceptability. So just because it's given once a week, if it is causing problems to the patient, they will not take it. So definitely adherence is a very, very important issue in terms of using appropriate weekly therapy. But I'm sure now when newer agents are really coming up, and hopefully we will have much better preparation in that regard. So it was a wonderful talk. There are a few questions which are coming up from there. One is that, is there any height benefit of GH therapy in familial short stature from Dr. Sivan? Again, it's the same thing. So it's like an idiopathic short stature. We have to be very cautious. We should not give therapy in all cases because that will cause confusion. If the child is very short, we can think of. Another question, 10 to 11 year age for the steroid priming, is it chronological age or bone age? It is chronological age and not bone age in that setting. Another question from Dr. C1 is, if patient develops edema with GH therapy, how do you manage? Now, what we usually tell them that if it is a mild edema, just ignore. But if the edema is quite significant, particularly there is severe headache, sometimes we have taken off therapy also for some time and then started at a much lower dose in that situation. Diuretics may be given but not required in most cases. I think final question from Dr. Pankaj, if mild OSA, can we start GH therapy, and how do we monitor OSA then if it gets worse? So actually speaking, when you talk about primary, the evidence is that the respiratory function improves with growth hormone. The only problem is that if you have severe OSA, there is a risk that if the sudden increase in that adenoidal hypertrophy can cause sleep apnea. So in that situation, you should go ahead and do a surgery, tonsilloadenolectomy, and then go ahead with therapy. Mild cases, you just monitor their saturation and the findings, and they will improve over time. So I think that was a very interesting aspect to go forward. I will now we'll go forward to the subsequent part of our talk, which basically is going to focus about further management issues and challenges. Now, one big challenge which happens in India is that we tend to have a diagnosis of growth hormone deficiency very late. And these patients present when there is already very limited time to grow. Now, what do we do in this setting? Whether we use a higher dose, we increase the duration of growth using GnRH analog or aromatase inhibitors is always a big question. And to answer those, we have got, we'll ask Dr. Pratik, who is currently working as a fellow in Regency Center for Diabetes, Endocrinology and Research. And we'd like to invite Dr. Pratik to talk about how pubertal modulation can be a way in terms of improving growth outcome in GHD and probably also non-GHD conditions. So over to you, Pratik.
Yes, sir. Is it visible, sir?
Yeah, it's visible. You can. It's visible.
So thank you, sir. So we have discussed exhaustively about the GH axis, GH-IGF axis. So now we come to how can we modulate the HPG axis in order to get optimum growth. So what happens in the HPG axis, as we know, the GnRH stimulus leads to pulses of LH and FSH, which ultimately cause increase in testosterone, which is further converted to estradiol with the help of aromatase. Now, this estradiol acts on the estradiol receptors, which causes increase in growth, and as well as the fusion of the growth plate, leading to formation of larger bones. So what all can we use? If we use GnRH analogs, which ultimately reduce the testosterone and estradiol levels, it can ultimately lead to decreased testosterone and estradiol levels, hence prolonging the pubertal growth spurt. We can use aromatase inhibitors. Now, these inhibitors prevent the conversion of testosterone to estradiol and hence reducing the estradiol levels. And so in this case, we have high testosterone and lower estradiol levels. And now, which is at an extremely experimental stage, the estradiol receptor antagonist can be used to decrease the levels of estradiol. Now, from a broader perspective, we would like a narrower perspective. So more than GnRH analogs, we would prefer estrogen receptor antagonists, but however, this is at an extremely experimental stage. So if we start with GnRH analogs, various studies have been done to exploit the fact that we can prolong the pubertal duration, hence increase the adult growth, adult height. So in the initial studies done as shown here, they showed that there was not much increase after usage of GnRH analogs, and we needed further studies, further prospective studies. In the 2009 consensus statement of GnRH analogs, it was shown that the use of GnRH analogs for conditions other than central precocious puberty requires additional investigation and cannot be suggested routinely. However, now a study has been published in the Endocrine Journal 2020 from China. Now, what they have done here, they have taken combined therapy in GnRH analog and growth hormone and given it to children who are short and with normal pubertal onset. So here they've included short children and excluded all pathologies such as growth hormone deficiency or tumors, and they've divided into ISS and non-ISS. ISS is those who have lesser than 2 standard deviation height, and non-ISS who are short without pathology but slightly taller than 2 standard deviations. Now what is seen here, there is a significant improvement in adult height. As we can see, boys have an improvement of 6.6 centimeters, girl had an improvement of 11 centimeters. And even if we divide, what is important in the non-ISS group also, there was improvement in height of 6.9 centimeters in boys and 11 centimeters in girls. Hence, they concluded saying that the treatment with GnRH analogs and recombinant growth hormone can improve the adult height SDS of ISS as well as non-ISS children with normal pubertal onset. However, in the following lines, they have stressed that randomized control studies are needed for further investigation to conclude on the topic of whether we can give GnRH and RGH to these individuals. Now, coming to the Growth Hormone Research Society, what is their perspective about GnRH analogs? They say that the GnRH analogs to delay epiphyseal closure as a single agent is not indicated. However, you may consider GnRH analog in combination with recombinant growth hormone only in GHD, in SGA or Silver Russell syndrome, but in the adult height, so the height SDS at puberty should be low. Now, use of growth GnRH analogs, the international consortium, which our sir was a part of, now they have divided basically what they say the use of GnRH analogs in GH deficiency can be done on only 2 situations. First, if the child was treated for malignancy with resultant growth hormone deficiency and CPP, yes, you can use GnRH analogs. But now this is controversial, as they mentioned. Children with growth hormone deficiency who do not have the catch-up growth, which is supposed to be there at the onset of puberty, as this will lead to an insufficient adult height, you may use, but again, this remains controversial. Now, what about non-growth hormone deficient causes of short stature? They have told that the growth hormone analogs alone or solo use lacks efficacy and should be considered experimental. But in small for gestational age, the combined growth hormone and growth hormone GnRH analog may increase the adult height, but you need to consider the potential advantages and disadvantages of treatment. Now, coming to aromatase inhibitors, as we discussed earlier, aromatase inhibitors can reduce the estradiol levels, hence preventing the fusion of growth plate. Now, how did it actually come into play? It all started actually when this case report or these case series actually showed that individuals with aromatase deficiency had an adult height much higher than what was predicted. So this actually led to a lot of studies regarding the role of estrogens in the adult height. So many studies were done. And finally, Leo Dunkel had released an update of the role of aromatase inhibitors in growth disorders in 2009. Now, there was a compilation of multiple studies of multiple pathologies such as testotoxicosis, McCune-Albright syndrome, CAH, and even CDGP. Now, some of these studies showed an increase in adult height, some did not show. Some of these studies showed only anastrozole only was used, or it was used in combination with testosterone, etc. And finally, what they said is that aromatase inhibition appears to be an effective treatment for boys, but however, several clinical important issues need to be addressed. And of course, due to the paucity of safety data, it should be considered experimental and should not be used outside research setting. Now, why are we stressing so much about the safety of these aromatase inhibitors? Now, as a study done by Dr. Anurag Bajpai only in Melbourne Royal Children's Hospital, it was seen that rats who were treated with peripubertal rats who were treated with aromatase inhibitors, there was a detrimental effect on bone strength. There was a decrease in bone strength, and prostatic hyperplasia was seen in the rats who were treated with these drugs. And also a study done by Hero et al. Showed and suggested that these use of aromatase inhibitors may predispose to vertebral deformities. And finally, in 2015, a Cochrane review was shown, and it showed that there was no evidence to support an increase in adult height. But all is not negative as far as aromatase inhibitors are concerned. In this study by Morris et al., where aromatase inhibitors, growth hormone, and the combination therapy given in pubertal boys with idiopathic short stature showed that there was, as we can see here, the combination shows a good increase in final height as well as net gain in height. And what is interesting is that the solo use of aromatase inhibitor, as we can see from the black block, there is improvement in height where the solo treatment is given as compared to what the CDC would have predicted for these individuals. So in summary, the use of combination aromatase inhibitors and growth hormone improve linear growth in more than GH alone and aromatase inhibitors alone in adolescent boys with ISS. It was also seen that the quality of life is improved when you give aromatase inhibitors and growth hormone in individuals who are idiopathic short stature when it was measured from both patients as well as parents' perspectives. Now, again, coming back to the Growth Hormone Research Society, what do they mention? They mention that the use of aromatase inhibitors in pubertal boys directed towards delaying the epiphyseal fusion could be considered, but again, remains controversial and off-label. And what about the consortium, international consortium guidelines of GnRH analogs? They too mention that the use of aromatase inhibitors for children in growth hormone deficiency again remains controversial and is not point of care. So I would like to conclude by saying GnRH analogs, yes, may be used in combination with growth hormone in GHD or SGA. Solo or alone use should not be done. Aromatase inhibitors showing benefit, but again, still remains experimental because of the adverse effects. Thank you.
Thanks a lot, Pratik, for a wonderful session that you discussed about these roles. And as discussed, aromatase inhibitors is a double-edged sword. It is causing deficiency of estrogen on one hand, and estrogen has an effect on the bone, on the reproductive system, on the brain, every part of the body, adipocyte. So if you talk about aromatase knockout mice, they have got a huge problem in terms of multiple issues. We study now, as I said, in mice study also, there were a lot of issues which were there. So you have to be careful about them. The other issue, of course, is that they will cause high androgen. So if you use them, they will become more muscular and more virile in that sense. You have to be cautious of that high androgen levels as well in that setting. So this is an interesting talk you talked about. Now what we'll do is that we are coming to our close of our session. The very important therapy which is left is the use of IGF-1. And this is something which is going to become important from that clinical perspective. Subsequently, we'll invite Dr. Riddhi to talk about IGF-1 therapy in growth hormone insensitivity. And this is an important topic which is often untouched in that regard. So Dr. Riddhi, you can go ahead with your presentation.
So thank you, sir. So this is the end of the today's exhaustive academic discussion. So IGF-1 therapy is actually FDA approved for primary IGF-1 deficiency. It is not routinely recommended for growth hormone deficiency or secondary IGF-1 deficiency. So what are the conditions where we can use the IGF-1 therapy? Before going to that conditions, just a few words and quick revision about the growth hormone action, which is already discussed by sir in the pathophysiology action. So growth hormone acts on growth hormone receptor, which has got extracellular domain, transmembranous domain, and intracellular domain, which act via Janus kinase pathway to phosphorylate the STAT5B, which then stimulate the state response element in the nucleus to produces the growth hormone dependent peptides that include the IGF-BP3, IGF-1, and acid labile substrate. Now this ternary complex enter into the circulation, and this IGF-1 acts at the target organ at type 1 IGF-1 receptor to produces the cellular growth and induces the linear growth of the individual. Now, primary IGF-1 deficiency occurs because of the defect at the level of growth hormone receptor, which is known as Laron syndrome. And the most common defect is in extracellular domain of growth hormone receptor. The other rarer causes of primary IGF-1 deficiency include the STAT5B defect, which is associated with recurrent infections, ALS defect, IGF-1 gene defect, or IGF-1 receptor defect. And even the growth hormone deficiency type 1A, where there is complete deletion of growth hormone gene, even a small exposure to growth hormone lead to development of the growth hormone antibody, where we need the IGF-1 therapy as a sole treatment. They do not respond to conventional growth hormone therapy. So all this condition, there is need for IGF-1 therapy. The common feature of all this condition is severe growth failure. Their height SDS is like -4, -5, -6. They do not present with mild growth failure. They have low IGF-1 level except IGF-1 receptor defect, where their IGF-1 level is high, otherwise IGF-1 level is low. And they have normal or higher growth hormone on stimulation test. So this is the common biochemical and clinical feature. Plus they have distinct clinical markers like shallow orbit, frontal bossing, as well as mid-facial hypoplasia. They are more sick looking, more severe growth failure. So these are the distinct characteristics by which we can know clinically as well as biochemically of the primary IGF-1 deficiency. Now, because primary IGF-1 deficiency is very, very rare, what Pediatric Endocrine Society guidelines suggest that it should be diagnosed based on the combination of parameters, that is oxological parameter plus low IGF-1 level, and all the causes of secondary IGF-1 deficiency must be excluded. This is very, very much important. We should exclude the undernutrition, then liver disease and primary growth hormone deficiency before diagnosing the primary IGF-1 deficiency. And growth hormone binding protein should be done before doing the mutation analysis or the IGF-1 generation test, because which is one of the most common cause of growth hormone insensitivity. And if its level is very low or undetectable, it confirms the diagnosis. And IGF-1 generation test and mutation analysis is helpful for diagnosing primary IGF-1 deficiency. So the diagnosis can be made based on the combination of parameters, not based on the single value or the single test. Now, in suspected condition, if there is absence of the genetic evidence, we should give a trial of growth hormone before starting IGF-1, because some of the mild cases of the growth hormone sensitivity may respond to IGF, the growth hormone. And if there is lack of response to conventional growth hormone therapy, that is in terms of increase in growth velocity less than 2.5 centimeter, even after 6 months of growth hormone therapy, then one should consider IGF-1 therapy. Now, IGF-1 therapy can be started since initiation if there is confirmed genetic evidences available for the hormone signaling defects like IGF-1 gene or IGF-1 receptor defect. So major differences in terms of conventional growth hormone therapy and IGF-1 therapy is in terms of mechanism, their side effects, and some of the major adverse events. So when we give growth hormone, it will act on growth hormone receptor in the liver to increases IGF-1 level, and this IGF-1 then acts on IGF-1 receptor to induces the linear growth. It will also increases IGF-1 production at the level of the growth plate. It will release the glucose by the process of gluconeogenesis. So it is diabetogenic, or it has a property of the insulin resistance, or it has property of the hyperglycemia. Growth hormone also increases the IGF-BP3 level. That's why the level of IGF-1 remain in physiological limit once we give growth hormone. While that is not seen with IGF-1 therapy. Once we give IGF-1, it will goes into the systemic circulation and act on IGF-1 receptor and increases the growth of the growth plate. So here there is no increase in IGF-BP3 level. So free IGF-1 level will increase in circulation beyond the physiological limit, and that has theoretical risk of malignancy. So we should be careful for this side effect. Secondly, IGF-1 act on insulin receptors, so it has risk of hypoglycemia, while growth hormone is associated with risk of the hyperglycemia or diabetogenic state. Thus, major differences is IGF-1 therapy has no paracrine effect. There is risk of hypoglycemia and it does not increases IGF-BP3 level. So free IGF-1 level increases too much at very high level and increases risk of malignancy. So we should be careful. Now, response to IGF-1 therapy, that is different and that is definitely inferior than the conventional growth hormone therapy, and that is beautifully shown in this study. That they have followed up 21 children where clinical as well as genetic diagnosis of primary IGF-1 deficiency was done, and they were treated with IGF-1 at variable doses of 60 to 120 microgram per kilogram twice daily subcutaneously for a mean period of 10 years. And what they have found that pre-treatment growth velocity of this individual was 3.1, and after IGF-1 it was increased to 7 in first year, 5.6 in second year, and subsequently 3.9 to 5 centimeter per year. So definitely the response is inferior to growth hormone therapy, where we found that the first year growth velocity increases around 10 to 12 centimeter, in second year around 8 to 10 centimeter. So the response is definitely inferior. Plus the side effects are more noted during the study period as compared to conventional growth hormone therapy. And so the average height SDS gain with the use of IGF-1 therapy of around 10 to 12 years is around 1 to 2 height standard deviation score, that is equivalent to 10 to 13 centimeter at adult height. So the response is very poor, and only caveat of this study was it was uncontrolled study. Variable doses of IGF-1 was used during the study period, and some of the patients received GnRH analog to defer the puberty. So that have also confounded the result of IGF-1 response. Now the dose that is recommended for IGF-1 is 40 to 120 microgram per kilogram twice daily, or single higher dose of 150 to 200 microgram. But what the study which is done by this fellow showed that pharmacokinetic profile of IGF-1 in Laron syndrome, or the growth hormone insensitivity state, that IGF-1 turnover is higher in this subject as compared to normal subjects. So it should be preferred to give it twice daily rather than once daily. And they have also compared the high dose as well as low dose of IGF-1 in around 21 children, and 14 received higher dose, 7 received lower dose. And what they found that the oxological benefit of both higher and lower dose is almost similar. There is no statistical significance between the two doses in terms of height gain. But what they have found that in higher dose group, there was acceleration of bone age after 2 years of therapy that resulted in the compromised adult height. Plus there is obviously cost will be high and more side effects are noted in high dose group. So it is preferred to give low dose, and that is twice daily in 2 divided doses. Adverse effect, most important and worrisome adverse effect is hypoglycemia. So it is strongly recommended by Pediatric Endocrine Society to give IGF-1 20 minutes after carbohydrate containing meal or snack. It should not be given in empty stomach to reduces risk of hypoglycemia. Other side effects, most important is the adenotonsillar hypertrophy after hypoglycemia, and that is seen more with the IGF-1 therapy as compared to conventional growth hormone therapy. Other side effect incidence is almost same with conventional growth hormone therapy, that is benign intracranial hypertension, slipped capital femoral epiphysis, and allergic reaction is also noted more with IGF-1 therapy as compared to the growth hormone therapy. And some of the studies have shown that even anaphylactic reactions are also noted during the study period. So we should be careful about these reactions. So the learning points from my talk is that we should always give trial of growth hormone if there is no evidence of genetic evidences for primary IGF-1 deficiency. Always beware of hypoglycemia while treating any patient of primary IGF-1 deficiency with IGF-1, and low dose twice daily regimen that is preferred for treatment with IGF-1. Thank you.
Thanks a lot, Riddhi, for the wonderful presentation. And we have really covered a lot of these topics. So we started at 3 o'clock and we started really from pathophysiology. We moved forward in terms of pointers of criteria. We talked about etiology, evaluation, management. We talked about growth hormone, long-acting growth hormone, IGF-1 therapy, and pubertal modulation. So pretty much everything has been covered in this period. And I'm really happy that all of the presentations were really very well and they were all evidence-based. And we'll see if there are any questions. There's one question from Dr. Pias regarding the mode of therapy in a child with Turner's presented 13 years ago. She was short stature. I think that's a very, very common presentation. The average age of presentation in India would be probably around 11, 12 years of age. In this setting, it is very, very difficult. I would say that if the bone age is 11 to 12 to 13, we may give growth hormone for at least 2 years and then try to induce puberty gradually. If in the Western recommendations, we talk about the availability of oxandrolone and using that in that setting, but that's not really available. So it is a challenging condition. The response to therapy will be less, but because there is no other option, it is better to start growth hormone first. Maybe a couple of years later, you can start thinking of giving the pubertal induction in that regard. So I think this has been a very exhaustive session covering everything. I will thank all the presenters from Dr. Neha, Dr. Chetan, Dr. Riddhi, Dr. Pratik, and Dr. Sajali, along with Dr. Sayan, who was in the overall organization of the program, Nikhil, who was involved in terms of the overall management of the setting, and very importantly to Pfizer. So I think this has been an interesting program to go on. And just a couple of announcements that we'll probably make in terms of the further program. So we will keep on having these modules. So till now, we've been doing big programs like the programs related to the practical pediatric endocrine course and advanced symposium. We'll also focus on smaller modules like multiple pituitary hormone deficiency, like diabetes insipidus in future. And I'd like to thank Genotropin for supporting this. You can access the entire modules in a much bigger fashion in the master course in pediatric endocrinology, which is available on the website. And you can also look at our book and the MediClasses application, which is available. So I'll just have a quick feedback from the speakers. Dr. Chetan, what would you like to convey in terms of the message?
Hello. Yeah, thanks, Dr. Anurag, for giving this opportunity to interact with you people. And I think we have come up with a nice module in form of growth disorders pertaining to the growth hormone and IGF-1 deficiency. And I hope we all have been able to give the answers to all the listeners regarding their questions and queries, and hope to see you all with the future projects as well.
Thank you, Chetan. Dr. Neha? Neha, are you there?
Yes, sir.
Yeah, Neha, your feedback?
Yeah. So thanks for the kind invitation, sir. So this was a very good platform to discuss about disorders which are not very well covered in our regular textbooks. So this probably has been very helpful for the listeners to go through the disorders which affect the growth hormone and IGF-1 axis. While routinely we just focus on growth hormone deficiency, and rarely one might be thinking about growth hormone insufficiency states. So after this module and after going through the topics on MediClasses, there might be coming awareness regarding these conditions as well. And thanks, sir, for such an elaborative session.
Thanks, Neha. Dr. Riddhi, you're there? Yeah, Dr. Riddhi. Yeah, what's your feedback on the overall program?
Thank you. So this was a very nice program, and definitely, as Neha's ma'am said, that this is very less of discussion and academic based. So my audience might have benefited from this short program of 2 hours. And thank you, sir, for this opportunity.
Thank you, Riddhi. Dr. Pratik?
Yes, sir.
Your feedback overall the program?
Yes, sir, it was a very nice experience, and I think we have covered everything regarding growth. And what was nice is the people are asking their doubts, and the doubts are being cleared by you, and we have covered all the aspects of growth.
Yeah. So once again, I have to thank all of you. We have to thank all the participants who joined us on this Sunday. We thank Pfizer for the support, the entire Grow India team. and we'll definitely join up. Every month we'll have one session in this regards. Thank you. Thanks a lot. We'll be putting up the videos on YouTube gradually, session-wise subsequently, as well as our website as well. So thanks a lot, everybody. Thank you.